Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee, and a warm welcome to all of you, respected faculty, dignitaries, and our audience who have tuned in from across the country for today's event, which is on high risk pregnancy. At the outset, let me express my gratitude to the Science Integra team who, through their Bridging Bharat Abhiyan, have conducted nearly 150 webinars in this lockdown period, and also to Bharat Serums and Vaccines, who are our education partners for today. Today's program is in association with four societies from within Rajasthan. But before we start the formal program, next slide, please. I need to place on record my gratitude to the AMOG's office bearers, our president, Dr. Nandita Palchetkar, immediate past president of FOXY, and currently the president of AMOG's. Thank you always for standing by us, supporting us, promoting and encouraging us in all our endeavors. Also to Dr. Arun Nayak, who is our secretary of AMOG's, past president of the Mumbai Society, and a very strong believer in continuing academic education. Sir is usually busy and rarely turns up for our programs, but hopefully next week we'll be able to have him in person at one of our events. Thank you so much, sir, for always standing by us. Next slide, please. I am proud to welcome my co-convener for today's program, Dr. Anju Soni. She is the chairperson of the FOXY HIV and AIDS Committee 2020 to 2022. She's been the president of the Jaipur Society from 2018 to 19. She's also president of the Jaipur Menopause Society in the past, 2017-18. Vice president also of the same society, North Zone coordinator of the FOXY Urogynec Committee, committee member of the Endoscopy Committee of FOXY, and of course, being an endoscopic surgeon herself, she has a special interest in critical care gynec, minimally invasive surgery, urogynecology, menopause, and high-risk pregnancy. Welcome, Dr. Anju Soni, to the program. Please unmute yourself.
Thank you, Dr. Pratik. Thank you
you
very
so
much
much.
for beautiful program to state of Rajasthan. I think it is the most needed program which we have the problem in day-to-day life. Thank you for bringing this program to Rajasthan.
Thank you so much for associating with us and with AMOG's. Next slide, please. To introduce our chief guest for today, I would like Dr. Anju Soni to please do the honors and welcome our chief guest, Dr. Mandakini Meg, chairperson of ICUG.
Dr. Mandakini Meg is a very well-known personality. We have all been seeing her in this webinar almost every day. The way she has changed this ICOG in last few months is commendable. She had been international vice president of MWIA Central Asia. She was also vice president of AMWI Central Council. She had lots of many posts like national vice president of FOXY, 12 and 13, and she has been past president of Indian Federation of Services. She doesn't get the introduction. Welcome, Dr. Mandakini, for being here and for blessing us with your knowledge and consent. Thank you very much, ma'am.
I'd like to invite Dr. Mandakini Meg, madam, to give us a few messages in her capacity as chief guest and chairperson of ICUG.
Yeah. So, good afternoon, everyone. At the outset, I'd like to thank. Am I audible?
Yes, ma'am. Please go ahead.
Oh, yeah. So, good afternoon, everyone. I really want to thank Dr. Pratik Tambe, Dr. Anju Soni, both convener of the today's very, very important topic of the high-risk pregnancy. I bring greetings from the ICOG, and to say about that high-risk pregnancy is very important topic of the ICOG certificate course also in the future incoming courses, certificate courses which ICOG is already holding. ICOG also, have this a training program for the NCD also, in which again in the high risk pregnancy, diabetes, hypertension will be covered. So I am very, very glad to know that you are covering so many important topics. You got an excellent faculty Dr. Geeta Balsarkar, I can see Dr. Sarita Bhalerao, Dr. Abharani Sinha, though she is actually, traveling, but she is committed to give lecture as a faculty is commendable. My younger brother and colleague Dr. Niranjan Chauhan, guest of honor, is also doing a great job as a he has done a great job as a secretary, huh? And wonderful audience. So I thank again, and I wish you all the best. Tomorrow we have governing council meetings and many meetings, so I have to rush. But I really wish you all the best for this wonderful seminar and taking up a very important topic of the national interest. Thank you very much.
Thank you so much, ma'am. We also have to officially place on record our gratitude to our chairperson of ICOG, Dr. Mandakini Meg, and Secretary Dr. Parag Biniwale for granting us the coveted ICOG credit point for today's CME and many other programs which we have done. Sometimes we take these things for granted, but in the COVID era, getting MMC or state medical council points has become difficult. So probably this is the only means of accreditation that we have for the
I
recent
want to,
past and immediate future. Thank you
Pratik,
so much, ma'am.
sorry, I just want to again add that MMC has started now charging also. But at the
Yes,
ICOG, we are so generous and we are, all the time giving in the middle of the night also. So many times we give the credit point, that is our accessibility, affordability, and everything. So thank you very much.
exactly. At very short notice, sometimes we have to send the email and the flyer, and it comes back within a matter of minutes, if not hours.
Minutes.
Thank you so much, ma'am.
Thank
Can
you.
we have
Thank
the
you.
next slide, please? It's my proud privilege to introduce today's guest of honor, who is none other than Professor Dr. Niranjan Chavan. Sir is the professor and unit head at LTMMC and LTMGH, which is also known as Sion Hospital for short. He's been the national coordinator for the Foxy Medical Disorders in Pregnancy Committee last year as well as this year. Chairperson of the Foxy Oncology and TT Committee in 2012 to 14. Sir is currently the Vice President of the Mumbai Society, the premises Secretary of the Association of Fellow Gynecologists in Mumbai, Chair and Convener of the Foxy Cell for Violence Against Doctors in 2015 to 16, Chief Editor of AFG Times, Course Coordinator for 11 batches of the Mumbai University recognized certificate courses, member of Managing Committee for IAG for 3 terms, I think, if I'm not mistaken, and course coordinator of 3 batches of advanced minimal access surgery at LTMGH 2018 to 19. I present to you Professor Dr. Niranjan Sir.
Thank you, Dr. Pratik Tambe. It's an honor as a guest of honor to be at the Association of Maharashtra Obstetrics and Gynecological Societies.
Sir, sorry
I
to
would like
interrupt.
to,
Your video is not seen.
okay, can you see me now?
Yes, sir.
Yeah, yeah. I would like to thank the office bearers of AMOX, Dr. Anita Palchetkar and Dr. Arun Naik, and the conveners, Dr. Pratik Tambe and Dr. Anju Soni, to invite me to be the guest of honor today's program. I would also appreciate the efforts which the ICOG chairman, Dr. Mandakini Meg is doing since she has taken the place of office. And there is a lot of activities of ICOGs which are going, and that we could see in the recent concluding elections of ICOG, where more than 94.34% of members took part in the ICOG elections, and that was the first, I think it is a world record or something for ICOG. Madam, you are doing a wonderful work, and I'm sincerely telling you from the bottom of my heart the efforts which you are doing as an ICOG chairman. Of course, Pratik, what should I talk about you? You are an amazing boy with
Thank you.
multi-talented personality and a zeal and passion for academics, which we can read and see through your CV. And I'm honored to be here amongst the great societies of Rajasthan. Actually, probably I might have come, my forefathers came from Rajasthan, Chauhans, and then they went to Kolhapur. And probably from there, my parents migrated here 60 years back. So I think I have got the same blood as Rajasthan. Dr. Anju Soni, I can see you smiling and being happy, but I feel I am probably a combination of a Rajasthani blood and a Maratha blood. But leaving away all those aside, we are all Corona warriors, and we have been doing a lot of efforts in our passion and disseminating knowledge. Knowledge is infinite and it is powerful, and that's what we are here for. So I appreciate the efforts which are taken by each of you, the chairman. And today's topic is by Dr. Sarita Bhalerao, my colleague and batchmate. She is going to talk wonderfully on a topic which is recurrent pregnancy loss. And then we have one more topic which is being presented by our Patna member, Dr. Abharani Sinha, and she is going to talk on malaria and dengue in pregnancy. So with this, I do not want to take any much of your time, but surely the most interesting and the icing on the cake will be the panel discussion moderated by my fellow colleague from AMOGS, Foxy and MOGS, Dr. Pratik Tambe, and we will be seeing a variety of cases. So I don't want to fall into your between, but I just request you to please vote for me and support me for the IAGE, that is the Indian Association of Gynecological Endoscopy elections, which will be there from 1st of October till 15th of October. And I want you to support your right choice and the best candidate, none other than Dr. Niranjan Chavan. And I'm hoping to be at the helm of affairs with your support. And I will see to it that endoscopy is taken to everyone and to all and every gynecologist. And I wish you all the best for a great success for this webinar. Thank you so much for inviting me.
Thank you, sir,
Best
Dr.
wishes.
Niranjan. We wish you all the very best in your quest and your future career, both at IAG and Foxy. His CV, I think, which was presented to us, is the old CV. It does not mention that sir has recently been elected as the joint treasurer of Foxy to take over for a tenure of 3 years starting 2021. So we wish you all the very best, sir, in your career forward in IAG as well, and hope you bring laurels to the Mumbai society as always. Thank you so much, sir. Can we have the CV slides of presentation for the chairpersons, please? Dr. Geeta Balsarkar is a friend and colleague since nearly 30 years. We have been born and brought up in the same institutions, undergraduate at KEM, postgraduate at Vadea Hospital. Madam is currently a professor at both these institutions. She is the clinical secretary of the Mumbai Society, vice president of the Menopause Society, Mumbai branch. She is the president of AMWI Mumbai branch. And most importantly, I think this should be top of her CV. She's the associate editor of the Journal of OBGYN of India, which is the Foxy Journal. And very soon she is expected to take over as the editor in chief of the same prestigious journal. We welcome Dr. Geeta Balsarkar. Next slide, please. Dr. Anju Soni, ma'am.
I would I would like to welcome Dr. Dinesh Godhan. He has been president of Bharatpur OBGY Society for last so many years. He's a senior practitioner working in Bharatpur, and everybody talks great about him. Of course, now his health is keeping slightly low, but otherwise he has been a very, very active member for Bharatpur. Welcome, Dr. Dinesh. I hope he's joined.
Thank you,
Can't
ma'am.
see. I would like to.
Dr. Prabinder Kaur Sudhu is the
Yeah.
president of Sri Ganganagar OBGYN Society, one of the societies which is collaborating in today's program. She is a very senior and respected member of Foxy, and she's been practicing since the past 36 years as a consultant, a living legend. We are delighted to welcome her here today for today's program. Next slide, please. Dr.
I
Anju
would
Soni,
like
ma'am.
to welcome Dr. Yeah, I would like to welcome Dr. Nidhi. She's a young, active president of Kota OBGY Society. She's consultant obstetric and gynecologist and director in Bartunia Nursing Home and Infertility Center. She has been awarded Woman of Substance Award by Times of India 2018. She has been also awarded by Women Inspiration Award by Rotary Club Kota in 2019. She has achieved 5 gold medals during her MBBS, and a Shankar Dayal Sharma President Award for the best all-round student. She is a very, very active person in the societies of Rajasthan, and wherever there is a need, she is always there for academics. Welcome, Dr. Nidhi.
Next slide, please. Dr. Renu Sethia is the president of Hanumangarh Society. Again, she's been practicing for the past 33 years as a senior obstetrician. We're delighted to be able to welcome her to the podcast.
इनके माउस पॉइंटर चल रहा है ना
I think Pratik has
I
lost
think
his
Dr.
connection.
Pratik, yeah,
Lost
please,
the connection, yeah.
Dr. Anju, can you please continue?
Take over.
Yeah. I think some problem with Dr. Pratik. I would like to invite Dr. Sarita for your program. Can you share a slide, or she will be sharing out? Dr. Sarita, welcome.
I will introduce my colleague and the one batch senior, Dr. Sarita Bhalerao, with whom we have been working for the past 25 years. She's a very dear colleague, and she's a past vice president of the Mumbai Obs and Gynec Society, the past chairperson of the AMWI Mumbai branch. She's also the past president of the Mumbai Menopause Society, and she is actively working in this fetal and perinatal medicine and colposcopy. She is a chairperson of AICC RCOG West Zone and a member of the ICOG Governing Council. She is attached to many hospitals and also the honorary clinical associate of the Wadia Maternity Hospital. She was the joint secretary of FOXI in 2017 and the quiz committee chairperson 2009 to 2011.
Thank you, Dr. Geeta, for that kind introduction. And at the outset, let me thank, Pratik is back, that's great. Let me thank Dr. Pratik Tambe and Dr. Anju Soni for inviting me to participate in this wonderful program with AMOGs and the Rajasthan societies. So can I share my screen now? Yeah. Yeah, can you see the screen? Is it okay and am I audible?
Yes,
am I audible? Yes?
Yes, ma'am, all good. Please go ahead.
Yeah. So thank you for giving me this wonderful topic of recurrent pregnancy loss, which is something very close to my heart. You know, in spite of all the advances in treatment, this is an area where there are still so many uncertainties. But thankfully, every few years, we have some developments and which improve our management of this very, very difficult condition. Now, let's start at the very beginning when we are looking at recurrent miscarriage and the definition. According to the RCOG, we are looking at 3 or more consecutive pregnancy losses before 24 weeks of gestation. According to the ASRM, we are looking at 2 or more consecutive failed but clinical pregnancies. So here the difference is, are we including biochemical pregnancies or are we looking only at clinical pregnancies? Once we start looking at biochemical pregnancies, the incidence is going to be much higher because many, many pregnancies do not reach the clinical stage. Now, practically speaking, initiation of evaluation is perhaps appropriate after 2 losses based on the patient's age and the desire for conception. So as clinicians, whether it's been 2 or whether it's been 3, whether they've been clinical or whether they've been biochemical, doesn't really matter. We really have to look at the patient's age and, start our investigation. Now, looking at the incidence, you know that spontaneous miscarriage is a common occurrence and it occurs in 10 to 15% of clinically recognized pregnancies. However, when we look at patients having 2 or more consecutive losses, the incidence is approximately 5%. 1% have 3 or more consecutive losses, and most clinicians consider recurrent pregnancy loss even if the losses are not consecutive. The biggest diagnostic dilemma is, why did this happen? And patients can, go on and on about it. So many times we try to counsel, we do all the possible investigations, and almost in 50% of the time we don't come out with any cause. But there are some known causes, of which genetic causes are very, very important, endocrine causes, and let's take a look one by one in short at all these important causes. The first one I'd like to address are the chromosomal abnormalities. About 40% of miscarriages in recurrent miscarriage patients are due to chromosomal abnormalities. We know that the risk is definitely related to maternal age, and as maternal age advances, there is a higher incidence of chromosomal abnormalities. Now, the next line may look a little difficult: meiotic chromosome segregation errors in oocytes. But this basically means that during the process of meiosis, when there is an aging oocyte, there is a higher chance of a chromosomal abnormality. And today, karyotyping is very, very relevant, very important and freely available. And it's not just doing karyotyping, but it's also the technique of karyotyping which is important, and the concept of whole genome approaches is very important. So this is where we are not looking just for 13, 18, 21, X and Y, but we are looking at the entire genome to look for problems. There is a high frequency of sporadic karyotype abnormalities in products of conception. These account for more than 50% of the losses. They may be whole chromosome abnormalities, partial chromosome abnormalities, or single gene disorders, or even rarer things such as microRNA defects or changes in gene function, which is not really clinically relevant. Now, this is a very nice review which has come from Rajasthan, and I'm very happy that I'm with the Rajasthan societies. And these people looked at miscarriages, and they looked at cytogenetic studies of recurrent miscarriages, and they came up with some very interesting points. First important thing is that if the pregnancy was lost at the anembryonic stage, then the incidence of chromosomal abnormalities is almost 90%. As it becomes embryonic, it's 50%. In the early fetal period, it's 30%. And beyond 20 weeks, the incidence of a chromosomal abnormality is only 10%. So as an earlier loss is more likely to be a chromosome abnormality as compared to a later loss. And the rate of aneuploidy increases with increasing maternal age. Maybe periconceptional folic acid may reduce this risk. Trisomy 16 is common in early abortus specimens. Trisomy 13, 18, and 21 common at later gestational ages. Maternal cell contamination can outgrow the aneuploid fetal cells in culture. These are some problems. And as I said earlier, more sophisticated methods of karyotype analysis, such as microarray, are probably indicated in these patients of recurrent miscarriages rather than the traditional karyotype. Now, advanced maternal age, the impact on risk of pregnancy loss cannot be overemphasized. Increased rates of maternally derived trisomies are known. Probable natural selection of better quality oocytes early in reproductive life, so that as a woman ages, the not so good oocytes are left behind. Oocytes which are recruited later in life are more likely to be abnormal or to experience errors at the time of meiosis. And in women above the age of 40 years, what we must remember is that the sporadic miscarriage rate is as high as 50%. This was a very nice slide, which I thought, and these figures, I put them up because it's helpful for us to counsel our patients. When you're looking at patients below the age of 30, spontaneous miscarriage rates are in the range of 10 or 12%. When we're looking in the age group of 30 to 40, they're 15 to 25%. But as the woman is 40 plus, the incidence of miscarriage is as high as 50%. That means 1 out of 2 will miscarry. Karyotyping of products of conception is something very simple. We can all do it. Collect it in a common syringe in sterile water or saline. Put a few drops of gentamicin. Ready collection tubes are also available, and we can send for fish as well, as that is fluorescent in situ hybridization and complete karyotype as well. Parental karyotype can also be done, and parental karyotypes abnormalities are seen in 3 to 5% of couples with recurrent loss. Balanced translocations are the most common structural rearrangement. They may be reciprocal or they may be Robertsonian translocations. There's a 25 to 50% risk of pregnancy loss, and they may at some point also produce normal offspring. What I think is that doing a parental karyotype is important. If something is found today, we have genetic counselors, and referring the couple for genetic counseling is also very important. Some single gene disorders may be associated with fetal loss, hemoglobinopathies like alpha thalassemia, multiple pterygium syndromes leading to mid-pregnancy fetal losses, and there may be some genes which are linked to cardiac cycles which are causing stillbirth, which also are more rare but could also be the answer. So something interesting is PGT, pre-implantation genetic testing, the answer? Now, couples, we are sending them for peripheral blood karyotyping. We're looking for balanced translocations. We're sending them for genetic counseling. But then what do we offer them? So the new terminology is pre-implantation genetic testing for aneuploidy screening, that is PGTA. And when we think of PGTA, it's an IVF procedure. It's you can either do a polar body testing or a blastocyst biopsy testing. And there's a lot of work going on right now. But at the present moment, ASRM still says that there's a lack of robust evidence, and we still need to know whether this technique is going to be the answer to these patients who have recurrent miscarriages. Now, changing gears, let's look at thrombophilias. Pregnancy is a hypercoagulable state, and women with heritable or acquired thrombophilic disorders have significantly increased risk of pregnancy losses. When we look at the inherited thrombophilias, we have the factor V laden, the prothrombin gene mutation, protein C deficiency, protein S deficiency, antithrombin 3. In these patients, stillbirths are more likely than early losses. There is a high cost of testing, but perhaps these thrombi are what are blocking the blood supply and causing the miscarriages as well as causing stillbirths in pregnancy. This is just a report of one of my patients where I have done a thrombophilia profile, and you can see that they are checking for protein C, protein S, antithrombin 3 level, factor V ladens, and then giving an answer. So these type of tests are available. And in patients with recurrent miscarriages, though they are expensive, one can do these tests and then find out these problems. Methyl tetrahydrofolate gene polymorphisms are associated with hyperhomocystinemia. Hyperhomocystinemia is a risk factor for neural tube defects and recurrent pregnancy loss. Here, folic acid and vitamin B12 is important, and therefore the message is to supplement these patients with not just folic acid, but also folic acid and vitamin B12 for all these patients. Now, when we look at autoimmune factors, there are certain autoimmune diseases which are associated with pregnancy loss. Systemic lupus and erythemosis, SLE, the first trimester loss risk is 10%, the second and third trimester loss is 6%. And we have the APLA syndrome, or the antiphospholipid antibody syndrome. And this is really one of the areas which is very, very satisfying. If you find it and we are able to treat it, it's been a breakthrough and you can really get good results. Antiphospholipid antibodies are autoantibodies which are recognizing various combinations of phospholipids and phospholipid binding proteins. There are many, many different antiphospholipid antibodies, but the important ones are the ones that I'm going to discuss. This antiphospholipid antibody syndrome is causing a syndrome of hypercoagulability and therefore causing miscarriage. Typically, these patients may have a history of vascular thrombosis. They have a loss of a fetus at or after 10 weeks, or a preterm delivery at or before 34 weeks, or 3 or more consecutive spontaneous abortions before 10 weeks. So these are the clinical features or the criteria that one should look for. Then we do the lab investigations where we look for the anti-cardiolipin antibodies, IgG or IgM. It's not enough to do just one test, but you have to do two tests. And if these antibodies are positive in moderate or high levels on 2 or more occasions at least 6 weeks apart, then we say that the anticardiolipin antibody is positive and there is APLA. And lupus anticoagulant antibodies should also be detected on 2 or more occasions at least 6 weeks apart. Now, these are all technically difficult to do. It's difficult to get these things, and there are lab to lab variations also. So these are problems with diagnosing antiphospholipid. There are other antiphospholipid antibodies like antiphosphatidylserine, which is nearly always associated with APS, highly correlated to cardiolipin binding, and others which have less correlation and no consistency. For the treatment of these patients, heparin anticoagulation is the answer. We give multiple studies have now proved the role of heparin and aspirin. We give aspirin in a dose of the 75. More recently, they have recommended 150 milligrams. Low molecular weight heparin or unfractionated heparin works equally well, and low molecular weight heparin has the important advantage of once daily dosage, whereas unfractionated heparin has to be given twice daily. The role of steroids is now very clear. It is not advocated for a recurrent pregnancy loss or for a recurrent miscarriage. But when the patient is a patient of lupus and requires herself to be in remission, then steroids may be indicated in conjunction with the rheumatologist. So aspirin, subcutaneous heparin, folic acid, B12 supplementation, and progesterone supplementation are indicated in pregnancy. Changing gears again, we go to the alloimmune factors. Now, this is an interesting concept where the fetus bears foreign antigens derived from the father. In simple terminology, the fetus is rejected instead of being accepted. Today, many advances have occurred in the field of immunology, and what studies have shown is that alterations in the behavior of the T lymphocytes contribute to the tolerance of the fetus, and the mother must develop tolerance to the fetus, and then the pregnancy will not be rejected. There is also a unique subset of immune cells called the uterine natural killer cells, which have been studied. And maintenance of early pregnancy, this is a very complicated picture, but the maintenance of early pregnancy is based on all these immunological changes, complement activity and the T helper cell count, etc. And all this basically contributes to a healthy implantation and development of immune tolerance. This was an interesting article which looked at natural killer cells and reproductive health. And here we know that there are two types of killer cells. There are natural killer cells. There's the uterine and there's the peripheral natural killer cells. We can't check the uterine natural killer cells, NK cells, but we can check the peripheral natural killer cells. And there's still a lot of controversy in literature whether these determining the natural killer cell count in peripheral blood, does it help these patients? But current evidence does not support routine testing of these natural killer cells, and more research is necessary. So you say possible therapies, what can we do? Can we give prednisolone? Can we give progesterone? Can we give intravenous immunoglobulins? Steroids, unfortunately, have not been shown to improve the outcome, and also have got some dangers in causing cleft lip and cleft palate. Progesterone is a very, very good immunomodulator, and progesterone is the best thing that we can give at the moment. Intravenous immunoglobulins, though theoretically have helped, there are no clear guidelines, and at the moment we don't have large-scale data to support the use of intravenous immunoglobulins. Progesterone is an immunomodulator. There's a shift it causes a shift from the pro-inflammatory TH1 cytokine response to the anti-inflammatory TH2 response, basically, which is pregnancy protective. That we must remember. Dihydroprogesterone produces progesterone-induced binding factor, and this PIBF is very, very important. It inhibits the cell-mediated cytotoxicity and the natural killer cell activity. And the PROMISE study is the large study which evaluates the progesterone levels. Looking at other factors, endocrine factors, definitely poorly controlled diabetes contributes to miscarriage, overt hyperthyroidism and overt hypothyroidism, yes. But when we look at subclinical hypothyroidism, does it really work? And today the literature says that if you have subclinical hypothyroidism, then it is controversial whether it's a cause. According to the American Thyroid Association recent guidelines, if the TSH level is above 4, then it is definitely hypothyroidism. It should be treated. If it is less than 4 and between 2.5 and 4, if the antibodies are there, anti-thyroid antibodies, then again the patient should be treated for this hypothyroidism to improve the outcome. When we look at PCO and pregnancy loss is higher with PCO, and many studies have now shown that it's the hyperandrogenism of the PCO, and these patients, once they are put on metformin, once they have weight reduction, their pregnancy outcome and their entire reproductive outcome will improve. Metformin reduces pregnancy loss in PCOS, and this was a retrospective study of PCOS women who became pregnant. They looked at two groups, and they found that the group which was on metformin had a better outcome compared to the group which was not on metformin. Luteal phase defects are a controversial cause of RPL. Studies proving luteal phase defects as a cause of RPL are lacking. No convincing studies show LPD treatment improves pregnancy outcome. And doing progesterone levels hasn't really helped. Doing endometrial biopsies hasn't really helped, because we don't know whether the serum progesterone levels correlate with progesterone at the cellular and the molecular level. So at the moment, what we know is that progesterone as an immune modulator is helpful. Progesterone reduces the risk of a miscarriage, and so all these patients who have recurring miscarriage when they become pregnant, they should be given supplemental progesterone. One of the most satisfying areas again is anatomic factors, and almost 15% of these recurrent first trimester losses have congenital anomalies. Variations of the double uterus are common. When you find a septate uterus, it's really very, it's encouraging, because these are amenable to resection. The septum can be resected very easily hysteroscopically, and the outcome is excellent. But when we look at biconjugate uterus, there is still an uncertain benefit of surgery, and the unification procedures have not been very popular. They are more difficult to do. And what happens is, with the biconjugate uterus, is that with every pregnancy the horn matures, and sometimes they get a better outcome with each successive pregnancy. But the septate uterus, when you find, it is definitely worth doing that. In other abnormalities such as intrauterine synechiae, such as submucous fibroids, what the guidelines say is that if they are distorting the uterine cavity, it is better to restore the uterine cavity. If it's a submucous fibroid, patient has had a miscarriage, it's better to remove the fibroid, and that she will have a better outcome later. Though these subserous fibroids do not come in the way, and though they say that unclear relationship between uterine leiomyomata and RPL, large submucosal fibroids do distort the cavity and occupy a large subendometrial area, and perhaps they cause mechanical constriction or inadequate placentation resulting from poorly vascularized endometrium. So these are just some pictures of the acquired uterine defects. You can see filling, you can see a submucous fibroid, you can see a polyp, and again, polyps, if they are small polyps, probably won't come in the way, but large polyps, submucous fibroids, adhesions, all these uterine factors should be corrected. Today we have 3D ultrasound. We can do either a good 2D ultrasound or a 3D ultrasound or a sonosalpingography or a hysterosalpingography or a hysteroscopy. All the options are available. I would personally think if 3D is available, 3D should be the first choice, followed by the hysteroscopy, and at the same time operative hysteroscopy. Now, coming to infection, no infectious agent has been proven to cause recurrent pregnancy loss, though Certain infections have been associated with sporadic losses or one spontaneous loss. And the classical torch titer today is we don't do, it is not recommended. It may be responsible for one loss, but not for recurrent losses. And doing the rubella IgG is only worth it because if they are rubella negative, you still can vaccinate them before the next pregnancy. So I think we shouldn't be doing the torch titer, but we should definitely do a rubella IgG to check if they are vaccinated. What about the male factor? Many people, workers have looked at the male factor and have looked at the semen parameters among the men whose partners have RPL compared to the WHO standards, and they've also compared it with those who have had successful pregnancies. But no, there's been no clear guideline, no difference in incidence of anti-sperm antibodies, and male factor contribution to RPL is unknown. And though there are some thoughts on DNA fragmentation, which may result in early embryo loss. At the current moment, we don't have clear guidelines as to whether the semen parameter should be tested and if there is, what one should do. So this was an interesting article in Fertility Sterility 2016, which looked at the relationship between sperm aneuploidy, sperm DNA integrity, chromatin packaging, and the traditional semen parameters and recurrent pregnancy loss. And I just want to draw your attention to the conclusion where the authors said that the increase in abnormal sperm parameters, sperm DNA fragmentation, and sperm aneuploidy suggests possible causes of unexplained RPL. So there is a possible cause. We don't know how, and we don't know to what extent, and we still don't know whether we should test these males and what we should. But what we can do is perhaps give them antioxidant, advise them about lifestyle modification, and that may help to correct the problem. So RPL males have a higher incidence of sperm aneuploidy, oligoasthenoteratospermia, and things. So environmental factors again are important. There's a confirmed association with radiation, with alcohol, mercury, lead, suspected association with high doses of caffeine, with hypothermia, fever, and cigarette smoking. So I think that what we can offer our patients is good, careful counseling to to improve their lifestyle, to improve their diet, bring down their weight, exercise. Just as is for so many things, it will have a beneficial effect on the RPL. Another area of interest is immunotherapy, where high dose intravenous immunoglobulin has been tried. Paternal cell immunization has been tried, and third-party donor leukocytes have also been tried. But when we look at the Cochrane database, it says that immunotherapy does not lower the risk of future miscarriage in women who repeatedly miscarry. But many workers have been working on this, and we hope that in the years to come, we have clearer guidelines. And today, there have been many successful pregnancies which have followed this. When we look at lymphocyte immunization therapy with paternal or third-party lymphocytes, the idea is to maintain the correct balance of Th1 to T2 cells, increase the T regulatory cells. There is a possible benefit in a small number of patients with unexplained recurrent spontaneous abortions. And the results may be conflicting because background success rate is high. So perhaps in those patients, in that subset of patients where there are unexplained recurrent abortions, you've tried everything, you've gone, there's no obvious cause, they may be the patients who should be referred for this therapy, as we don't have anything to offer. And here, this is an article by our own Mohan Raut and Mugdha Raut from Mumbai, and they have run the immunotherapy center for the prevention of repeated miscarriages here in Mumbai, and they have very, very encouraging results, and they have reported their results, and they said that immunology plays a very important role, and they have reported encouraging pregnancies with this therapy that they are doing. And finally, we have the idiopathic. More than 50% of couples have no explanation despite extensive evaluation. And the only thing we can offer is informative and sympathetic counseling, which in itself appears to play an important role. 70% live birth rates reported in couples with unexplained RPL who undertake an untreated subsequent pregnancy. So what I tell my patients is, look, when you try again, your chance of, even after 3 miscarriages, your chance of having a live birth is still higher than having another miscarriage. And we give them all the support, we encourage them, and we hope for the best. So tender, loving care, giving them a ray of hope, lifestyle advice, sympathetic counseling in the absence of no treatment at all. Remember that the fetal salvage rate will still be 60 to 80%. And obesity management, healthier lifestyle, refrain from tobacco, alcohol, illicit drugs, and stress management will perhaps go a long way in helping these patients. So in summary, I'd like to conclude by saying early pregnancy loss is a frustrating entity, not just for the patient, but also for the provider. And year after year, these patients come and they sit in front of us and we really don't know what to do. Try to encourage them. Remember that the possibility of a successful pregnancy outcome is high. Of course, depending on the maternal age and the number of prior losses, these are the two factors that will prognosticate what will happen. Understanding the potential underlying mechanisms of the loss with empathetic supportive care decreases the emotional stress and facilitates cost-effective evaluation and therapy. So it's worth going back into all those reports, worth finding out what really went wrong, to spend time and evaluate all the possible causes, and at the end of the day, give them the supportive care. And with that, I thank you all for a patient hearing. And once again, thank you to our MOGs. Thank you to Dr. Nandita Palshetkar and Pratik and Dr. Anju Soni and the Rajasthan Societies. I'm very happy to be on this program.
Thank you so much, ma'am, for that wonderful and exhaustive presentation. We have nearly 500 viewers who have logged in, and we are waiting for some of the questions to come in. As soon as they come in, we'll have a chance to ask you. If we don't have any immediately, we would request that you wait for a little while. Unless you have an outreach today, ma'am, if I'm not mistaken.
Yes, I have, but there's time.
Okay. So requesting the chairperson to please present their closing remarks on the first talk and introduce the next speaker, Dr. Abharani. Can we have the CV slide for Dr. Abharani Sinha, please? Is Dr. Anju Soni there? All right, since nobody seems to be speaking and it's my program, I think I should go ahead. It's my proud privilege to present Dr. Abharani Sinha. She's been the president of the Patna OBGYN Society in 2017-18, past chairperson of the quiz committee of FOXY 2017, executive member of the ISOPAB, and teaching experience of more than 25 years. She has several publications in national and state journals. He's contributed chapters in various FOXY publications, joint organizing secretary for EICU 2014, which was held in Patna. And of course, she has a special interest in high-risk pregnancy. We'll be speaking on malaria and dengue in pregnancy. Today, it seems there's some unseasonal rain and bad traffic. So Madam is still traveling. We thank her for having joined us. She has very kindly emailed me the presentation. And if I may be allowed to share my screen, then I'll be sharing the screen from here and Madam will speak. Hopefully we don't have any network issues while we are trying this new format of presentation. Can you see the screen?
Hello?
Yeah.
Yes,
Yes, sir.
we can hear you.
Yeah, Pratik, am I audible?
You're audible, ma'am, loud and clear. Stage
Hello.
is yours. Please go ahead.
Okay, thank you so much. And at the outset, I'd like to thank AMOGS, and I welcome all the societies from Rajasthan who have joined today. And my special thanks to Dr. Pratik Tambe, who has invited me to talk today on malaria and dengue fever in pregnancy. Next slide, please. May I have the next slide? Yes. burden. It is a public health problem, and about 19 countries in sub-Saharan Africa and India
Madam, sorry to
85% of
interrupt.
the global malarial burden. And
Can I just
worldwide.
interrupt, please? Requesting you
Yes.
to keep your video off
Yes.
because there are some glitches in the
Yeah.
transmission. Please go ahead. Sorry to interrupt you.
I have put it off, Dr. Pratik. Now it's okay?
The video is off. That's fine. Please go ahead.
Yeah. So if you look at the global burden, it's a huge public health problem, and about 85% of the global malaria burden is carried by 19 countries in the sub-Saharan Africa and India, and 6 countries accounted for more than half of all malaria cases worldwide. And if we next please. If we look at the burden of malaria in India, India has done quite well in the past few years, and it has showed a tremendous progress in the fight against malaria, with almost a 26 lakh drop in malaria cases in comparison to 2017. And India has reported an estimated 67 lakh malaria cases in 2018. Even the number of deaths due to malaria has gone down by 40% in 2018, and India now accounts for only 3% of cases of total number of cases across the globe. Next, please. Well, malaria has unique features in pregnancy. Like, malaria is more common in pregnancy compared to the general population, and the pregnant women are particularly vulnerable to Plasmodium falciparum infection because red cells infected with the placenta with the parasite can sequester in the placenta. The increased prevalence of malaria in pregnant women has been attributed to the immunological and hormonal changes which are related to pregnancy. Higher prevalence is seen in younger women, in their first or second pregnancies, in HIV-infected women, and women in the first and second trimester. Next, please. We all know that malaria is a vector-borne disease, which is caused by the protozoan Plasmodium. Amongst all the species, the most dangerous one is Plasmodium falciparum. Next is Vivax, malariae, ovale, and even a species known as Knowles is known, which causes malaria and Meckel, but can't infect humans. But even can infect humans. Next. Next, please. Malaria can be transmitted by the bite of an infected female Anopheles mosquito. However, the infection can be transmitted as a congenital infection or even by blood transfusion. If we look at the life cycle, it has got 2 hosts. The human is the intermediate host, and the mosquito is the definitive host. And the infective form for human is the sporozoites, which are in the salivary gland of the mosquito. And the incubation period is 9 to 14 days for falciparum, 12 to 18 days for vivax and the ovale, and 18 to 40 days for malaria. Next, please. It is important to know the changes in the placenta because placenta is the preferred site of sequestration and development of malaria parasites. What happens is that the intervillous spaces are filled with parasites and macrophages, and therefore they interfere with the oxygen and nutrient transport to the fetus. Along with this, there is villus hypertrophy and fibrinoid necrosis of the villi, and all the placental tissue, they exhibit the malarial pigments. Next, please. Coming to the pathogenesis, the key finding of Plasmodium falciparum malaria in pregnant women is parasites in the erythrocytes, which are sequestered in the intervillous space, which expresses a specific class of variant surface antigen, that is pregnancy-associated malaria variant surface antigen. And this mediates adhesions of infected erythrocytes to chondroitin sulfate and on the syncytial trophoblast lining the intervillous space. VAR2-CSA is the major VSA-PAM involved, and antibodies formed in response to VSA-PAM, particularly anti-VAR2-CSA, prevents adhesions of the infected erythrocytes to the placenta. Next, please. Next, please. Coming to the clinical presentation, the malaria can be either complicated or it can be uncomplicated. In uncomplicated malaria, there is less than 2% parasitized red cells, and there are no signs of severity or any complicating features. The WHO defines severe malaria with more than 2% of parasitized red cells in low intensity transmission areas, or more than 5% of in areas of high transmission. The CDC definition of severe malaria indicates a parasitemia of more than 5%. Next, please. If we look at the symptoms of malaria, there is fever, chills, and sweats, and the intervals between the fever can give us some indication of the species of malaria. It is less than 48 hours in Plasmodium vivax and ovale, 72 hours in malaria, and irregular high-grade fever in falciparum. There may be associated headache, muscle pain, nausea, vomiting, diarrhea, cough, or general malaise. Next, please. If we look at the lab and clinical findings, there may be prostration, impaired consciousness, respiratory distress, pulmonary edema, multiple convulsions, circulatory collapse, shock, abnormal bleeding, and features of DIC, jaundice, and at times hemoglobinuria. Next, please. Coming to the diagnosis, there are three mainstay of diagnosis for malaria. The most important is microscopy, where we visualize the parasites in the stained blood smears. Then rapid diagnostic tests, which detect the antigen or antibody, and the molecular techniques. Next. Blood smear microscopy is the most important gold standard method for diagnosis, and this gives us three information. Number one, the presence of parasites. Number two, the quantification of the density of the infection. And number three is the determination of the species of the malarial parasite. And all of these three information are necessary for providing the best appropriate treatment. However, microscopy cannot reliably detect very few parasitemia, or it also requires substantial training and expertise. So then comes the role of, next please, then comes the role of the rapid diagnostic test. For making a blood smear, we can make a thin smear or a thick smear. In thin smear, we can identify the parasite species, and it can also measure the parasite density. Whereas with thick smear, we can know the presence or absence of the parasites and estimate the parasite density, but we cannot get the information about the species. Next, please. So, how frequently should these blood smear be done? If malaria is suspected and the initial smear is negative, then additional smear should be prepared and examined over the subsequent 48 to 72 hours. And the CDC recommends requiring a thick and thin smear every 12 to 24 hours for a total of 3 sets before ruling out malaria. Next, please. Now, this is a chart showing the blood smear microscopy. How does it come to the diagnosis of the species? We have to look at the size of RBC, the number of parasites per RBC, the form of trophozoites, and other features. Next, please. About RDT, they are good tests because they can give result as early as 2 to 15 minutes, and especially useful in resource limited endemic settings because of its accuracy and ease of use. Next, please. How to select an RDT test? That will depend on the epidemiology of infection in the region where the test is being used, and the regions where infection is primarily caused by Plasmodium falciparum, use of an assay that detects Plasmodium falciparum only may be sufficient enough to be effective. And in regions where other infections are there, accordingly we choose the RDT. Next, please. Currently, there are RDTs like HRP2 and PLDH or Plasmodium aldelis, and accordingly, we, depending on the epidemiology, we choose the test. Next. As I said earlier, the limitations are that it cannot distinguish between all the species and may be less sensitive than microscopy. It cannot quantify the parasitemia, and an RDT positive test may persist for days or weeks after an infection has been treated and cleared. Therefore, they are not useful for assessing the response to therapy, and therefore both positive as well as negative RDT must always be confirmed by microscopy. Next, please. The molecular tests, they are more used in the research settings, and they are not used routinely, and they are mainly used for efficacy studies for anti-malarial drugs, vaccines, and evaluation of other diagnostic agents. A test called loop-mediated isothermal amplification may be developed as a field assay, but still they are not used commonly. Next, please. So now coming to the management. For management, we have three components. One is the treatment of malaria, then the management of complications, and then lastly, the management of labor in a patient who is suffering from malaria. Next, please. The treatment should be always prompt in pregnancy. We have to assess the severity by looking at the general features, looking at the labs, the hemoglobin, the parasite count, the liver function test, and the blood sugar. And these patients have to be monitored very intensively. The maternal and fetal parameters should be monitored 2 hourly, the RBS 4 to 6 hourly, the hemoglobin and parasite count 12 hourly, and the renal function test, liver function test, and the output input every day. Next, please. The treatment will depend upon the severity of the disease and also upon the gestational age. And WHO recommends that in endemic area, the treatment should start within 24 hours after the first symptom. If it is an uncomplicated malaria, we can go for an OPD treatment. But if it is a complicated malaria, then hospitalization is needed. Next, please. The choice of drug depends on the severity of the disease, upon the sensitivity pattern, the epidemiological resistance pattern, and the available data regarding the safety of the drug and the class of the drug in pregnancy. Next, please. If we look at the WHO recommendations, for all trimester, the first line of the drug is chloroquine or quinine. The second line is artesunate groups like artemether and artemether. And in the second and third trimester, we can also give a combination of pyrimethamine and sulfadoxine or mefloquine. NMR has guidelines 2010, which says quinine in first trimester, chloroquine for Vivax, and artemisinin-based combination therapy for treatment of falciparum in second and third trimester. That is artemisinin combination therapy containing mefloquine should be avoided in cerebral malaria due to neuropsychiatric complication. Next, please. There are certain drugs which are contraindicated in pregnancy like tetracycline, doxycycline, primaquine, and haloperidol. Next, please. So, the WHO recommends that all women in the second or third trimester with uncomplicated Plasmodium falciparum should be treated with ACT, that is artemisinin-based combination therapy, and complicated malaria should be managed in ICU settings. Next, please. So, for uncomplicated falciparum, the choice of drug is in the first trimester is quinine plus clindamycin for 7 days, and alternative could be an ACT or oral artesunate plus clindamycin. For Plasmodium falciparum uncomplicated malaria during the second and third trimester, the choice is always ACT therapy for a 3-day course. And if it is a complicated malaria, we have to go for parenteral artesunate treatment. Next, please. These are the doses. Let's move on to the next slide. For non-falciparum, if it is chloroquine sensitive disease, then definitely chloroquine is the first choice. In the second and third trimester, she can be treated either with chloroquine or ACT. And if it is a chloroquine resistant non-falciparum malaria, then in the first trimester, she should be treated with quinine. And those in the second or third trimester, they should be treated with ACT. Following, it is important to know that there may be relapses when it is a Plasmodium vivax or oval infection. Therefore, these patients, they should receive treatment for prevention of relapse. Chloroquine prophylaxis throughout the pregnancy can prevent relapse. Next, please. Now, coming to HIV infected pregnant women, they respond to the same treatment which is given for malaria. But those patients who are already on cotrimazole, one should avoid treatment with combinations of artesunate with sulfadoxine and pyrimethamine. And those on zidovudine, they should avoid treatment with artesunate and amodiaquine. Next, please. These are the doses. In chloroquine, we all have the experience that there may be a lot of vomiting, so it should never be started on empty stomach. And if there is a vomiting immediately after taking the drug, within 30 minutes, then it should be repeated. Next, please. Supportive management is very important during pregnancy. We have to take care of anemia, especially if the hemoglobin level is less than 5 grams. Hypoglycemia is another very important complication. So we need to monitor the random blood sugar, and these are treated either with IV dextrose or with an bolus. Septicemic shock is also seen with malaria, which is also known as algid malaria, for which we need to give third generation cephalosporin and other antibiotics. Patient may present with acute pulmonary edema, convulsions, or at times renal failure. And these all patients should be managed in the ICU settings. Next, please. The obstetric complications could be abortion, preterm labor, FGR, fetal heart rate abnormalities, abnormal Doppler studies of umbilical artery. It could be an intrauterine fetal death, stillbirth, or a postpartum hemorrhage. Next. Next, please. Can I have the next slide? Yes. During pregnancy, if the patient is having an acute clinical malaria, an ultrasound examination should be performed to evaluate the amniotic fluid volume, the fetal size, and the fetal well-being. The women who have recovered from an episode of clinical malaria during pregnancy, surveillance for fetal growth restriction should occur approximately every month, or I say every 3 weeks after 28 weeks, because these women, they are prone to develop fetal growth restriction. During labor, careful monitoring of maternal and fetal parameters should be done, because fetal distress is quite common. And since these patients, they may have high fever, so all efforts should be made to bring the temperature under control by cold sponging and antipyretics. Next, please. So there are certain poor prognostic parameters, like if the parasitemia is more than 5%, PCV is less than 30%, hemoglobin less than 7.1, hypoglycemia with blood glucose less than 40 milligram percent, if there is low level of glucose in CSF fluid, and others like low level of antithrombin 3, peripheral cystotemia, increased serum creatinine, or increased blood urea. Next, please. Now, there can be vertical transmission leading to congenital malaria, and it occurs particularly when there is an infection at the time of birth and the placenta and cord are positive for malaria. And the prevalence of congenital malaria varies from 8 to 33%. So all neonates whose mother developed malaria in pregnancy should be screened for malaria with standard microscopy of thick and thin blood films at birth and weekly blood film for 28 days. Next, please. There may be recurrence of malaria in pregnancy, and PCR studies have shown that there may be recurrence, and most recurrence occur around day 28 to 42, but sometimes there may be also late recurrences, which may have been reported as late as 121 days. Next, please. Coming to the prevention, pregnant travelers should be advised to defer travel to areas where risk of acquiring malaria is high until after delivery is feasible. And non-immune pregnant women who cannot defer travel to an endemic area should take chemoprophylaxis. Next, please. Other measures like bite prevention, repellent creams, mosquito sprays, insecticide-treated beds, and clothing protection, there are other measures for prevention of malaria. Next, please. Now, chemoprophylaxis. As I said, all pregnant women who remain in the malarial endemic area during her pregnancy should be protected with chemoprophylaxis. And the choice of chemoprophylaxis is chloroquine, which is the safest drug in pregnancy. And in areas where there is resistance to chloroquine, there we have to offer them a combination of sulfadoxine plus pyrimethamine, mefloquine or proguanil can be useful. But when these drugs are used, they should be started only after the first trimester. Next, please. For HIV-infected women in malarial endemic area, WHO recommends co-trimexazole prophylaxis regardless of the CD4 cell count and throughout all trimesters of pregnancy. The prophylaxis consists of a daily dose of sulfamethoxazole 800 mg and trimethoprim 160 mg because this provides protection against malaria as well as HIV-related opportunistic infections. Next, please. These are the doses for prophylaxis. Next, please. Now, what is intermittent preventive therapy in pregnancy? This is based on the assumption that every pregnant woman in a malaria endemic area is infected with malaria. Therefore, every pregnant woman should receive at least 2 treatment doses of an effective anti-malarial drug. And the drug that is most currently considered effective is a combination of sulfadoxine and pyrimethamine. It should be avoided during the first 16 weeks. The other promising alternative in women without HIV infection is DP, that is dihydroartemisinin and piperacin. Next, please. For HIV-infected pregnant women in malaria endemic area, the WHO recommends recommends regardless of CD4 cell count and throughout all trimester of pregnancy, a daily dose of sulfamethoxazole 800 mg and trimethoprim 60 mg. This provides protection against malaria as well as HIV-related opportunistic infections. Next, please. Now, there's another intervention, that is intermittent screening and treatment of malaria in pregnancy. Intermittent screening and treatment of malaria in pregnancy is an alternative strategy to IPTP. ISTP, that is screening, involves screening of pregnant women for malaria with a rapid diagnostic test, and at each antenatal visit with anti-malarial treatment reserved only for those with identified infection. ISTP may be useful in areas of lower transmission levels where the prevalence of malaria in pregnancy is low. Next, please. With this, I come to my talk, end of my talk on malaria in pregnancy. And now we move on to dengue fever. Should I move on, Dr. Pratik? Am I audible?
Yes, ma'am, loud and clear. There's some echo, but please go ahead.
Okay. So, well, About 40% of the world's population live in dengue-prone zone. WHO estimates at least 100 million infections which occur every year, including 5 lakhs DHF and nearly 22,000 deaths. Next, please. If we look at the burden in India, we have a rising trend of dengue fever in our country. And if we compare with 2013 with 2017, we really see a rise. Now this, next please. The causative agent is the arbovirus of the Flaviviridae family and Flavivirus genus. There are 4 serotypes of the dengue virus, DEN 1, DEN 2, DEN 3 and DEN 4. In India, DV2 was found to be the most prevalent virus. The likelihood for development of severe dengue is highest among individuals who are infected for a second time by a different dengue type from the first infection. Next, please. The vector for dengue fever is Aedes aegypti, which breeds near human in relatively fresh water pools or collections. It is these mosquitoes, they are preferably daytime feeders and often move on to another host, frequently taking multiple blood meal in a single breeding cycle. Thus, an infected mosquito may transmit the dengue virus to several individuals within the household. Next, please. Susceptible humans become infected after an infected female Aedes mosquito takes a human blood meal. The viremia in human begins towards the end of a 4 to 6 day incubation period and persists until around the time fever abates, which is typically 3 to 7 days. Once infected, these mosquitoes, they carry the virus for their lifespan and remain infective. Next, please. If we look at the clinical presentation, there are 4 main characteristic manifestations. First is continuous fever for around 2 to 7 days. This is followed by hemorrhagic tendency as shown by a positive tourniquet test. There may be petechiae or epistaxis. There is thrombocytopenia, that is platelet count is less than 1 lakh. There may be evidence of plasma leakage, which is manifested by hemoconcentration, which can manifest as pleural effusion or ascites, or with an increase in hematocrit, which is 20% more above the average for age, sex, and population. Next, please. So this is how a tourniquet test is performed. The blood pressure cuff is inflated to a midpoint between the systolic and diastolic pressure, and a test is considered positive when 10 or more petechiae are seen, about 1 inch in size. And this test may be negative or mildly positive during the stage of profound shock. So we have to be careful about it. Next. There are 3 phases of dengue: the febrile phase, the critical phase, and the recovery phase. Next, please. In the febrile phase, the fever is usually between 0 to 7 days. There may be a biphasic fever, but here it is very important to know that monitoring in the defervescence phase and looking for the warning signs is very crucial to identify the progression of the disease into the critical phase. Defervescence usually occurs between day 3 and day 8 of illness. Next, please. Here we can see the different phases, how it passes from the febrile phase to the critical phase and the recovery phase. Next, please. So here we have to understand what are the warning signs. The warning signs are the abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement, and there may be laboratory increase in hematocrit with a rapid decrease in platelet count. So if we get these warning signs, we know that now the patient is moving towards the severe disease. And in severe disease, we may have shock, we may have fluid accumulation with respiratory distress, there may be severe bleeding, or there may be severe organ involvement. Next, please. The obstetric complications may be preterm birth, low birth weight, oligohydramnios, antepartum or postpartum hemorrhage, fetal distress, miscarriages, intrauterine death, or even neonatal death. Next, please. Then there may be vertically transmitted neonatal infection, and that can be detected by RT-PCR. And the reported vertical transmission rate is 1.6% with no difference in the pregnancy outcome of the infected women. At or near term delivery, severe fetal or neonatal dengue illness and death may occur when there is sufficient time for the production of protective maternal antibodies. Next, please. The diagnosis, as we all know, that the primary test is NS1 antigen test, and then we can look for the IgM antibody capture ELISA test. And RT-PCR is definitely the confirmatory test with 95% specificity. Next, please. The differential diagnosis could be all types of fever like malaria, leptospirosis, typhoid, typhus, bacterial species, bacterial sepsis, and all causes of thrombocytopenia like gestational thrombocytopenia, immune thrombocytopenia, preeclampsia, HELLP syndrome, acute fatty liver of pregnancy, microangiopathic hemolytic anemia and thrombocytopenia, and autoimmune disease. Next, please. The management, the mainstay of the treatment is symptomatic treatment. We have to give IV fluid replacement, broad spectrum antibiotic, blood transfusion and blood component therapy. All the maternal and vital parameters should be monitored very closely. Serum electrolytes should be monitored, and we have to have a special monitoring of the blood coagulation profiles. Next, please. During labor, in critical phase of dengue, blood and blood products should always be cross-matched and saved. Trauma or injury should be kept to the minimum if possible, and it is always essential to check for complete removal of the placenta after delivery. Transfusion of platelet concentrate should be initiated during or after delivery, but not too far ahead of delivery, as the platelet count is sustained by platelet transfusion for only a few hours during the critical phase. Next, please. Next, please. For prevention, we all know since it is a mosquito-borne disease, approach to prevention is mosquito control, personal protection measures, and vaccination. We have to reduce the breeding size, larva control, endosymbiotic control. All these things, they help to prevent the disease. Next. Vaccination has been licensed in over 20 countries, but still they are not approved for travelers who are visiting, and it's not even commercially available. And the WHO also recommend use of CYTD and TDV vaccine only for individuals with lab evidence of previous dengue infection. So it is not given in the primary disease, but it is recommended for those who have a lab evidence of previous dengue infection. Next, please. So I would like to conclude that malaria and dengue are the two major causes of preventable indirect maternal mortality in India. WHO's intermittent preventive therapy in pregnancy is promising to prevent malaria in pregnancy. National vector-borne disease control program should be implemented more strictly, and public awareness programs should be arranged, and mothers, ANCs, during their ANC should be counseled to prevent stagnation of water and to promote local cleanliness. Thank you so much. Thank you, Dr. Pratik, and thank you whole MOX team for inviting me to talk on this subject of malaria and
I think that was fantastic and exhaustive. Thank you so much, ma'am. I think you're really a fantastic committed Foxian. In spite of being inconvenience because of heavy rain and traffic, you still were there well before time, and you managed to present. Hats off to you. Amazing.
And finally, I reached home also. Thank you so much.
Yes. We'd like to invite some comments from all the assembled dignitaries and the chairpersons. We have just been informed that there is an audience of 675 who has logged in here today. We had two excellent and fantastic speakers. I request you to please present your remarks. In the meantime, I will check if there are any audience questions which can be put to the.
We have some questions. We have Pratik. We have some questions.
I'm just checking for the
Pratik,
audience questions
Pratik,
in between.
I already have questions. We'll ask them once the chairperson gives their comment. Yeah.
Yes.
Chairpersons?
I think you will need to invite them to speak because even after the first speaker, they had not responded.
Yeah. So, thank you very much. Both the speakers gave an amazing presentation, and it was really nice to listen to such an elaborate and such a complete presentation. I think we are all overwhelmed with their presence. Now, I would like to ask few questions which have come from the audience. Dr. Krishnan Pal from Jaipur wants to know, will you manage 18 weeks of pregnancy with rubella positive in a TOG group? How will you scan USG at what stage? This question is to Dr. Sarita Bhalikar.
Is Dr. Sarita Balaram ma'am there? I think she may have been there. Let me just confirm. No, I think Madam had another event today for the Mumbai Society. It's an outreach program from South Bombay. I think Madam has left.
So, would you like to answer, Pratik?
Yeah, as far as rubella is concerned, if there is rubella which is proven in pregnancy, we are all well aware that rubella in pregnancy is associated with congenital anomalies, and usually this leads to complications. If there is active rubella infection during pregnancy, then usually we would recommend a termination of pregnancy or a very guarded prognosis depending on the ultrasound findings.
Next question is from Dr. Rebecca. She is not asked any question. Dr. Santosh Martin from Jaipur has asked for role of vaccination for DPT and swine flu in pregnancy.
So I think this is not really relevant to either of the two topics which was discussed today because we discussed malaria, dengue and recurrent pregnancy loss. As far as my knowledge goes, this doesn't fall into any of those topics. So perhaps we can move to the next question.
Next question is from Dr. Krishnpal Singh, and he is asked that how will you manage a 28 weeks pregnancy, twins with oligoheteroneous, one fetus, fetal heart is absent?
Again, this is not relevant to today's topic. Can you move on, please? If there are
So
relevant questions, Madam, I would request you to put in. Or if the chairpersons have any doubts that they want to ask, any clarifications from Dr. Abarani Sinha. If there are none, then we can present closing remarks, thank the chairpersons and move on to the panel then.
And I also thank Dr. Anju Soni. I missed her name. So thank you, Dr. Anju Soni. Nice meeting you.
Nice meeting you too, ma'am. Your presentation was very beautiful.
Thank you, Anju.
And you have reached home safely.
I was just traveling and I don't know how many honks you people must be hearing.
No, it went well. It was fantastic. Thank you so much.
Thank you. Thank you.
Yeah. Meenal, may I request you to please show us the slides for our panelists, please, because they've been waiting since the beginning of the program.
I would like to
proceed with the panel.
Dr. Prerna Rathore is an MBBS from SP Medical College, Bikaner. She did a government job for 15 years. Then she took VRS. Now she is running her own hospital. She just had an emergency and she had to leave. So we'll have to miss her. Next. Meenal, next person. Pratik, you would like to talk about Dr. Savita?
Dr. Savita Lalgadia has been serving since 21 years. She has her own hospitals in Sri Ganganagar. She deals exclusively with critical care obstetrics and she's also excellent at ultrasound. She's been the secretary of the Sri Ganganagar Society for 5 years. She's conducted several CMEs and webinars on a regular basis. And she has also been participating in social welfare activities regarding health education and checkups. She's been awarded by Giants International Prerna. Thank you so much for joining us, ma'am. Next slide, please.
Next, please. Meenal. Dr. Sangeeta Agarwal is MBBS DGO from Bharatpur. She has been running her own hospital, Bharatpur Nursing Home. She's practicing for last 20 years and she's very, very active doing social activities. Welcome, Dr. Sangeeta.
Next slide, please. We have with us Dr. Ajay Mane. He is presently the chairperson of the website committee of MOGS. We are really privileged to have sir with us. He's been a chairperson for the Adolescent Health Education Committee of MOGS for 2 tenures, and each of these lasts for 2 years. He's also been the chairperson of the Sexual Medicine Committee of FOXY in the past, National Coordinator for the Adolescent Health Education Committee and Food and Drug Committee of FOXY, been second joint secretary of MOGS in the past, a very well-known and respected figure in teaching and academic circles from Aurangabad. Thank you so much for joining us, Dr. Ajay. Next slide, please.
Dr. Prerna Kishan, she has been trained in FOXY affiliated endoscopy USG. She is E-Zone leader YTP FOXY. She is Eastern member breast committee FOXY. She is chairperson IMA Mission Pink Health Assam. She is conferred with prestigious FICOG, awarded Wonder Foxian in 2019, Northeast Woman of the Year in Health 2019, publication in various FOXY newsletters and chapters, special interest in high-risk obstetrics, sonography, mass scale awareness, and adolescent health. Welcome, Dr. Prerna.
Dr. Parvati Det is from the Government Medical College at Ernakulam, and she's an associate professor there. She's had several achievements to her credit, including the first prize in the free paper presentation at Impact in Trivandrum 2012, first prize in the postgraduate quiz at UFOXY South Zone in Madurai in 2012, first prize in the postgraduate quiz at AICH Mumbai 2013. She's a trainer for EMOCALs in Kerala, vice captain of MD and MSR in Ernakulam, and of course, her area of interest is high-risk pregnancy, which means she's eminently suited to this panel, which is on reducing cesarean section. Next slide, please. I think we had one more panelist, which was Dr. C. Vijay Lakshmi. Unfortunately, a couple of days back, she called me saying that she has high-grade fever with suspected COVID. We're hoping that she pulls through and she does well. We wish her all the very best, and we present apologies on her behalf. Today's panel is on reducing cesarean section rates, and I'm going to try and share my screen. Hopefully, I'll be successful in doing so. Is it visible?
Yes.
All right. So I would request all the panelists to please unmute themselves. This is a simple panel on something which we do day in and day out, and often we take it for granted. But given the current scenario in which we live, we need to talk a little bit about how we can try and reduce cesarean section rates and how we can be a little more accountable in daily practice. I start with Dr. the well-known English writer E.M. Foster's quotation, which says that the main facts in human life are 5: birth, food, sleep, love, and death. We're here to talk about birth. And if you remember the headlines from our newspapers over the past couple of years, you'll find that there are many headlines like this where some of us, black sheep amongst our fraternity, are giving all of us normal 99% healthy practicing obstetricians a bad name because maybe they are doing some unnecessary cesarean sections, charging patients more money, and then patients get the feeling that this is all a racket. This is just done to increase the amount of payment that the hospitals can demand, increase the amount of bills, and unnecessary cesareans are being done. That is the backdrop for today's discussion. Of course, this has decreased a lot in the COVID era since the turn of the pandemic, but it's still a very relevant issue that as organizations and as leaders, all of us need to address and we need to talk about. So this is going to be put to everybody in the panel to just get you warmed up. And I'll start by asking you, how do we classify these cesarean sections? Do we actually classify? In the good old days, 25, 30 years back when we were students, there were only two classes of cesareans. One was elective and one was emergency. Maybe there was a semi-emergency, but it was not really clearly defined. And that was fine for most of us. As far as front page entry went, or entering into the birth record or the surgical OT register, this simple classification was more than enough for us. But today things have changed. Today we don't use that simple classification of emergency and elective cesarean section. We need to have other classifications. We need to have something which is much more elaborate. And sometimes it's difficult for us to understand. So let's start by asking Dr. Jaimane sir, do you feel that this new system of classification that we have been told to adopt is something which is practical and relevant? Can we actually do it? Is Dr. Jaimane sir there? Dr. Jaimane sir? Dr. Jaimane sir? Dr. Jaimane? I think sir is experiencing some issues. Yes, Pavitra Algadia. About this issue. Please unmute yourself and you can speak. Madam, you will need to unmute yourself and you will need to speak. Backend team, can you please identify where is this audio issue and cut it off? Let's invite somebody else to speak on this. Dr. Sangeeta Agarwal, ma'am, would you like to contribute to the discussion? You will need to unmute yourself before you speak.
Not possible.
Yeah, we can hear you. Go ahead. Yeah.
Am I audible?
You are audible. Am I audible? But there is an echo. I think you have two devices.
I think you have two devices. I think you have two devices. I think you have two devices. I think you have two devices.
Can you please log out from one device?
Jigar, can you identify what is the problem? We are getting a lot of echo.
Now I am audible?
Yes, you are audible.
Yes, ma'am.
I am audible?
You are audible. You need to start speaking.
Dr. Pratik, I am audible?
You are audible, madam.
Please continue.
Please continue. If you are facing issues, we'll go to somebody else. Dr. Prerna Keshan is logged in. Can you tell us a little bit about classification of cesarean sections?
Yes, sir. Regarding classification of cesarean section, we can categorize it into 4 categories as per WHO. Category 1, where we have emergency cesarean section, where there is life-threatening risk to both the mother and the baby. In category 2, we have no life-threatening condition to the mother and the baby, but there is definitely an emergency and there is a compromise for both the mother and the fetus. Category 3.
Disturbing sound.
The category 3, we have there is no life-threatening condition to the maternal or the fetus, and neither is there any compromise. But these mothers, they require delivery at an early time. And category 4 is where we can go ahead with a planned section as per the suitability of the staff and the doctor. And if we go into the audit, as per the audit system is concerned, we are supposed to classify cesarean as per the Robson's Group 10 classification, which depends on parity, which depends on the gestational age, the position of the presentation of the fetus, the duration of pregnancy, and previous C-sections, and also like whether she's a primey or a multi. Like in Robson's group 1, which we have primey, which is more than 37 weeks coming on spontaneous labor, and group 2 is primey at more than 37 weeks with either induced or having pain already, and group 3 is multiparous with previous having already in spontaneous labors, and group 4 is multiparous female with induction or having a previous group 5 is something which we go for previous cesarean section cephalic more than 37 weeks, and group 6 is nulliparous breaches. Group 7 is all multiparous breaches, including previous C-sections. Then Group 8 is all multiple pregnancies, including previous CS. Group 9 is abnormalized, and Group 10 is all single cephalic for less than 36 weeks. So there's the Robson's Group 10 classification, which is actually required for the audit purpose. But in our day-to-day practice, it's quite difficult to maintain such a charting or to maintain such a in log, but we'll definitely after this cesarean section panel, we are definitely trying to make ourselves more
I think you deserve a standing ovation, because in all humility, I don't think I would have been able to recite all those 10 different classifications. Very honestly, fantastically done. Well done. Dr. Ajay Mane sir, I think you're raising your hand. Please go ahead.
Yeah. I'm sorry for the network connection. It was unstable, basically.
Yes, sir.
She has explained everything. But the first 4 categories, they are cephalic presentation, mainly to say. And in ICOG manual, they have given a percentage rather. I mean, the WHO has given a Robson criteria wise the percentage of category 1, it's 10% of the seizure. Category 2, 20 to 35% of the cesarean section rate. 3. Category 3, which is a multi-cephalic single spontaneous, it is only 3%. And category 4, it is 15%, and category 5 is the maximum, 50 to 60%, I must say. And category 8 is 60, and category 10, which is less than 37 weeks, is 30%.
Thank you, sir. So I think you've highlighted very beautifully that different indications are associated with different percentages or incidences of cesarean section. And that is why we need to have a much more broader classification as compared to what we traditionally were taught about elective and emergency. This is important for us to analyze our data. It's also important for us to keep records. And as you've already mentioned, since there are some standardized rates which are now coming forward, we need to check whether our rates are equivalent to these international standards which are accepted and published by WHO, or whether they are exceeding these, where we are falling short, and how our practices are different in our practice in India as compared to these international standards. Very beautifully brought out. And this brings us very nicely to the concept of audit cycle. Is Dr. Parvati Dev there, madam?
Yes,
Would you like to comment a little bit about what is this audit? Because in all honesty, let me say, that 20 years back, if you had asked me what is audit and what is research, I would probably have been able to answer you what is research, but what is audit, I probably would not be able to answer. Can you tell us something about this audit side?
In simple terms, I would say audit means it's a process of self-correction. As a department, in department, what we do is that every day morning, we have a morning report in which we discuss all the cases, all the LSCS, and all the anomalies that have been conducted, and the indications of each LSCS will be scrutinized in detail. And this Robson's classification we enter in saturation register, and for every case of cesarean we do, whether it be elective or emergency, we have separate column for the Robson's classification, because it helps us easily to rectify, find us which all way we can correct it, because the major where we can correct ourselves is mainly the first 4 classes, that is category 1, 2, 3, 4. After that it comes the previous cesarean and all, that all is possible only in tertiary care centers. Where we can correct ours is majority of them falls in the category 1 to 4. So an audit helps us to find out where this has gone wrong and where we need correction. In our institution also, we had very high rate of cesarean section, and we found out that the major problem was in our induction. And since we resorted to mechanical induction Follies, our cesarean rate has fallen tremendously. So audit helps us to correct ourselves and will help to correct and will find out the new path to reduce the cesarean section.
Thank you. I think she's explained it very beautifully. And this concept goes something like this. You look at what is the current scenario in your institution. For example, it might be how much time it takes you to see a patient after she has landed up in your OPD. In some places, the patient may have to wait for 3 or 4 hours before she is allowed to see a doctor because there are 100 patients before her in the queue. So, is there some way that we can set standards? Say we set a standard that every patient has to be seen within half an hour or 1 hour after she lands up in the hospital. That is a standard that we are setting. Next, we measure what is the current practice. In a busy antenatal OPD, sometimes patients may take 2 or 3 hours before they are allowed to see a doctor because there are many patients in the queue in front of them. So then we compare what the existing conditions are compared to what the standards we are hoping to achieve. We try and implement some changes. For example, more doctors may be there. We call in people from other units to assist in the OPD, or we try and route the patients in such a way that high risk patients are seen by the consultant. The consultant doesn't see general OPD patients, those are reserved for other people in the unit, like the juniors, where usually we expect that not much intelligence or expertise is required. And after a period of maybe 3 months or 6 months, you do the entire audit process again and check whether there is an improvement. So if there is a reduction in waiting times from say 2 or 3 hours to 1 hour, then you have achieved your objective. Whatever implementation of changes you have proposed and managed to achieve, that is working. This is the idea of audit cycle, and all of us need to imbibe this idea, implement it in our own practices so that we can improve, our healthcare approach can improve, and hopefully this will help to implement better standards and, of course, content delivery and healthcare delivery to our patients as well. As far as accountability is concerned, everything that we have discussed so far in this panel indirectly talks about us being accountable as care providers, as healthcare professionals, and as doctors, not only to patients, not only to authorities, but also, I would say, to ourselves. One of my favorite quotes: accountability is the glue that binds commitment to results. I want to bring back the people who had some audiovisual issues. I think that was Dr. Savita Lalgaria and Dr. Sangeeta Agarwal. I hope you've managed to sort out those issues. And I'm going to ask you, what do you think FOXI and ICOG as organizations have done on this front? Do you think they have contributed something to this entire debate, or is it still something which is not really properly addressed? Dr. Sangeeta Agarwal, ma'am, do you want to respond to that? No, I don't see anything. Dr. Ajay Mane sir is raising his hand. Please go ahead, sir.
Pratik sir, regarding the FOXI ICOG perspective, they have released a book, GCPR, on the induction of labor, basically. And the second thing, they have started one Manyata and Laksh Manyata program, which is there for the standard setting, safety, and accountability and accreditation, basically, for this from the house of FOX. And it is a very nice program where you can have 16 standards to have a standardization procedure of a labor room, along with the Manyata is added by government of Maharashtra, and I hope the rest of the states they will be adding very soon. It is a 10 more standards for the operation theaters and all the things. So it is a very good program. Everybody should follow that. Right?
Thank you, sir. So Manyata and Lakshya Manyata are basically a one-of-a-kind project which is launched by FOXI, ICOG. It's a public-private partnership in association with the government of India and the individual state governments. In fact, Karnataka, Maharashtra, and Rajasthan are the three states where this program has actually been launched 3 years ago. Rajasthan is one of the very important states where this program has been launched. There are certain basic clinical standards for safe vaginal birth and cesarean section, which have been published. And if you're interested, you can get in touch with the Foxy team at the Foxy office. There's a special unit called as the NPABU, which is headed by our Foxy president-elect, Dr. Hrishikesh Pai, and my good friend Dr. Amay Purandare is also there on that team. They'll be very happy to guide you. In case any of your staff needs proper training and needs to come up to these standards, they will be happy to provide that as well. And Foxy and Manyata accreditation is one of the things that all of us who run private practices, small clinics, nursing homes should be looking forward to doing, because this is one way in which we can ensure that all of our practices, especially for the paramedical staff, are safe, standardized, and they are accredited. As I said, we are the first in the world to launch this. It's not been done anywhere else. There are so many other countries who now want to get back onto this, and they want to also launch it in their countries. We are looking to us for our experiences and for how we are trying to implement the entire project. Let's go to the cases. We have a 30-year-old. Yes, sir.
Pratik sir, yesterday only we have completed 100 centers recognition as a Manya.
Fantastic. Congratulations, sir. Thank you so much.
Congratulations to you, sir.
Thank you so much. So this is the first case. A 30-year-old primigravida has an uneventful antenatal course, good class of patient, regular with follow-up visits, confirmed dates. She's now reached 39 weeks. She is on examination, a single cephalic engaged presentation with 3 kilos baby, and all the tests are normal. Like any primigravida, she's scared. She's afraid of labor pain. She's scared of the process of vaginal delivery, and she wants to do an elective cesarean section. Now, I don't know how common it is in Rajasthan to see this, but in a major metro city like Mumbai, we are now facing the situation where educated, good class of patients don't want the entire process of 10, 12 hours of labor pain and then to have a normal delivery. They would rather do an elective planned cesarean section at a time and place of their convenience and choosing. And in the old days, we used to talk about obstetrics of convenience. I think this is now obstetrics of patient convenience that we are addressing. Would anybody like to talk about this entire issue and how we can try and prevent this or address this?
So first of all, we need to actually find out how well informed the female is regarding the pros and cons of the cesarean section. It is not that normal delivery has complications, cesarean section doesn't have complications, or cesarean section doesn't end up in having pain. But she needs to be well informed about all the routine procedures that we are going to take her up with the antibiotics, with the IV fluids, with the post-operative care, and she needs to be referred to a healthcare personnel, apart from a doctor even, that who can explain her about the perinatal morbidity and mortality risk of cesarean section as well. We can't just take her up just because she's afraid of having labor pain. Her main issue of getting the choice of cesarean section is that she is fearful about the labor pain event. So it's not only the fear that can indicate that she needs a cesarean section. We need to have a thorough counseling class for her. We need to sit with her. We, as well as some other healthcare personnel like the paramedical staff who can actually, the nursing staff who can actually tell her that okay, it's not a very big issue to get a labor pain through. There are many females who are going through it, so she can at least give a trial of labor. In all settings where an emergency cesarean section can be taken up, she needs to be counseled for giving a trial of labor, and if in case she doesn't end up in having a good progression of the labor and then delivering in a very healthy with the CTG monitoring and a intrapartum monitoring, and then she can be taken up with a cesarean section if emergency arises. But for all practical purposes, we need to find out how well informed she is about cesarean section also, and then whether she is mentally assured that she needs to get ahead with the delivery process. Either it is painful or not painful, she has to undergo cesarean section. Even if it is a painful procedure, cesarean section also gives some amount of pain post-operatively. Otherwise, at the end of the day, when we do a cesarean section for her and she has that post-operative pain, she'll catch our collar and say, you said that there's no pain during cesarean section. So that is all we need to, each and every step need to be counseled with in complete detail.
I think you've covered all the major important points. Often it happens that this fear factor which is there can be addressed right in the third trimester, starting from the seventh, eighth, ninth month, whenever the patient has registered with you, by doing some simple antenatal classes, breathing exercises, simple walking, all those things which we normally suggest. And they can be reinforced by having multiple couples or multiple patients who are close to term talking to each other like a support group. And this will go a long way towards reassuring the patient and ensuring that she is open to the idea of a vaginal birth. Otherwise, there will come a time when there will be 90% elective cesareans just because we don't want to hurt the patient's and her relatives' sentiments. And maternal request prior to onset of labor will become the biggest indication for a cesarean section. And we should try and avoid that from happening anytime in the near future. So we've tried to convince this lady that okay, let's wait and watch. Everything is okay. It's reassuring. Otherwise, the CTG is okay. You don't have any actual pain. There is no reason to induce you right now, and there's no reason to do an elective termination with a planned cesarean section either. Is there something that we can do to examine her and identify whether she is going to deliver? In the old
We
days,
can
we used to do an internal examination to do something called as cervical
membrane
typing.
sweep. Yeah,
Yeah,
yeah.
okay, membrane
We can
stripping. Okay, go
yeah
ahead.
we can go ahead. Yeah, we can go ahead with a vaginal examination, per vaginal examination, and examine how does her Bishop score look like. Whether she is having an engaged head, whether her cervix is dilated, whether she is having the position is fine, whether consistency is okay. We can apart instead of getting into induction, we can go for a membrane sweeping prior to going for active induction, so that we can at least see if she delivers by 40 weeks or not, with simple procedure like that. In case she goes into labor, it's fine. If not, after 40 weeks, you can plan for her induction.
Okay, thank you for bringing the topic up. Since you've already started the discussion, I'm going to ask Dr. Parvati Dev to comment on this. Do you think this Bishop score, which you were taught in undergraduate years, is still practical and relevant in the 21st century? Does it really have any
Yes,
bearing on how we manage
yes,
patients?
sir. Definitely, sir. Definitely, it has got a role.
All right. So, how would you actually go about doing this membrane sweeping? Is it something for which you need to take a consent? Do you need to inform your patient beforehand that this is what you are doing? Or you just do an uncharted sweeping and then the patient comes back running in the middle of the night saying that, Doctor, I'm having bleeding after you did internal.
No, sir.
अरे वो उसका बोला ना बच्चे वाला
Console, can I request you to mute everybody else, please?
हैं बच्चा की ई है का अच्छा हाँ 542 का ठीक है
Meenal,
Hello.
backend team, do you need some coffee to wake you up?
Yes.
I have some, I can share with you. It's a big enough mug. Please mute everybody else. Thank you very much. Yes, we were discussing membrane sweeping. Dr. Parvati, please go ahead.
Yes, sir. Membrane sweeping has got a role because it helps in the pregnancy going past date. And though it is a bit uncomfortable for the patient, but as Dr. Prerna said, in the antenatal class itself, the fear for I'm just taking a bit of the previous question also. The fear for this vaginal delivery can be avoided to a major extent by taking a proper antenatal class. The patient should be aware of how the pregnancy progresses, what all complications occur, what is happening during labor, and while can even try that while the patient is waiting in the OPD, you can just put some, give small booklets or pamphlets, or you can put the posters over there. What are the adverse effects of cesarean section? What are the advantages of normal vaginal delivery? Short videos, short films can be projected in the television, which you have kept in your OPD. And second one is the allowing a companion in the labor room, which she is comfortable with, whether it be her mother or husband or a mother-in-law. Anyway, husbands, as of now, our labor rooms will not be so husband friendly. So we can try if the mother, but make sure that the mother has also attended the antenatal classes with this lady. And third one is labor analgesia. If these three, if we bring a change in these three factors, the patient will be very much comfortable. So that this member, when we admit the patient, she herself will know that she will have an internal examination, and we can just give a brief summary of what we are going to do. That we are going to introduce your two fingers. We are just going to see if the space is adequate for your baby to come. If the cervix is a door for the baby to come, we want to just see that whether the door is opening. Is there any complication? Once you explain and do the internal examination, the patient won't be so fussy. It's a fear for it.
Yes, so I think this underlines the fact that we often take our position as doctors as granted, and we don't often explain what we are doing. We don't talk to the patient, we don't allay her fears, we don't address whatever issues she might have. Once you have explained what you are doing, most patients would be ready for an internal examination or a membrane sweeping. But having said that, the likelihood of the patient having liver induced with a simple membrane sweeping is quite low. You need to at least do 8 to have one patient go into labor. Having said that, it's a good non-pharmacological method. There are other methods as well, including various things which have been described in the textbooks. And particularly in India, I think mothers-in-law are very fond of castor oil. I have a lot of my patients who land up with castor oil inductions in the middle of the night. I don't know what is your experience, but let us go to the actual experience that we were to talk about when we have to induce labor in these patients. So, Dr. Ajemane sir, what do
I would like to add something on lighter note. That the Hindi movies, they have added the fear of labor, because whatever they show, the crying and very much panic situation of the labor room, and the doctor coming and saying I can save only mother or baby, whom do you want to save? That creates a panic in the pregnant woman. We conduct in our hospital, we conduct Garbha Sanskar and antenatal yoga classes for them. For 15 days, each batch is there. We conduct that. We as Parvati ma'am said, we show them brief videos of animations and pros and cons of normal delivery and cesarean section, and make their muscles prepare for the normal day. Thank you.
Thank you, sir. I think that's a very good and valid point, and maybe more of us need to implement that in our clinical practice. Having very busy obstetric practice, often all of us as seniors forget to address these basic simple issues. Let's go back to the issue of how do we induce labor in a low-risk primary gravida who is now at term. We've already talked about the Bishop score. Having built on that Bishop score, Dr. Prerna Keshan madam, how do you feel you would like to address the issue of what are the factors which predict success of labor induction? Are there any specific things that you are looking for which will say, no, this patient will not be successful?
We can see the stations. Most importantly, before induction of labor, we need to see whether her head is engaged or not. The engagement of the head is the most important issue here, and we need to see whether the station is good and whether she is dilated a bit or not, and the position and consistency of the cervix. And prior to induction of labor, we need to have a checklist of documentation of the fetal heart rate, most importantly, and that too with an electronic fetal monitoring if it's possible in the bedside, and as well as the maternal condition and the fetus having any signs of any leakage or any signs of sepsis out there. That is very important. We need to see if there is having any leakage of the amniotic fluid, and these all things have to be taken into account, whether she is and if in case we find any leakage, then we need to ask her about the history and the duration of leakage she is having. Most importantly, the most important checklist is the engagement of the head, the dilatation or the position and consistency of the cervix, and the Bishop score has to be properly filled in, and as well the fetal heart rate needs to be closely monitored. Needs to be very closely monitored.
In near-term patients, we usually do have nowadays great machines. So we can have pelvimetry and diameter assessment, and so that we can avoid further complications, the macrosomia and all that.
Thank you, sir. I don't know if we do X-ray pelvimetry anymore. Mostly it is now clinical pelvimetry. And in certain patients where you are giving a trial of labor, maybe MRI can be thought of, but that is only for exclusively tertiary institutions. Most of us in private practice probably don't have access to that. But thank you so much for bringing that point up. Is Dr. Savita Lalgadia there? She had some audiovisual issues. I'm not sure if she's there. Could you respond, please, if you're there and we can hear you? No, I don't see her. So I think this is a good patient safety checklist to have, and you will agree with me that because of the increasing incidence of patient dissatisfaction and medico-legal issues which we obstetricians are facing in everyday practice, it's important to document everything. Even small things like a consultation with a counseling session have to be documented, not only in the patient's papers, but you yourself as a clinic or a hospital have the responsibility to maintain those records, and those records should be maintained even for low risk patients, because you never know what is the outcome of that pregnancy until that baby and mother have both safely gone home. So these are important issues that we all need to be aware of. So while we're talking about induction of labor, I would like to think that if we induce more patients at a proper and appropriate stage, and we learn the science of induction of labor, probably our incidence of cesarean section could be reduced in one way or another. There are various different points which we've discussed in this first case, and we will, I think Sir had mentioned about the induction of labor GCPR, which was published in June of 2018. This was released in Dr. Jaideep Malhotra's year when she was FOXI president. Dr. Shanta Kumari, who is now, of course, our president-elect of FOXI, was the chairperson of ICOG at that time. This is available free of cost on the FOXI website. If you don't have it, please have a look at it, download it, read it, imbibe it, and try and practice what it says, because this is an excellent single volume reference for everything related to pregnancy and induction of labor for Indian patients. This is a very excellent resource. If you can't find it, please write to me. I'll be happy to send it to you by email. This is also our Secretary General, Dr. Jaideep Tang, talking about the FOXI position statement on cesarean section rates. And this is available on our FOXI website as well, which talks about how this controversy has spiraled and ballooned into something great, which is not something which we have failed to address. FOXI also had an audit of clinical techniques, which is called as the FACT Conclave. This was on the day before the FOXI Presidential Conference in November of 2019. It was published subsequently, and all the attendees who had attended AICOG 2020 at Lucknow received a copy of this in the kit bag. Again, this is freely available. If you can't find it, please feel free.
So I want to add one thing here.
Yes, please.
Yes, as for the induction of labor is concerned, I just wanted to share a practical memory of my college days in Medical College, Kolkata, sir. Our VS, when he used to come for the morning rounds, he used to induce at a stretch 30 mothers, and by evening rounds, almost 80 to 90% females would have delivered. So that particular thing was always in our head during our clinical practice, that okay, if we induce properly with proper scoring, then definitely it gives good results. So our VS gave us this morning rounds we used to induce, and by evening 80 to 90% would have delivered.
True. So this is a practice which all of us need to learn. It's an art which nobody is born with. It is only finally honed with more and more experience in looking at practicing. So let's go to the next case. This is a 30-year-old primigravida. She's come at 11 o'clock in the night. She has a spontaneous rupture of membranes at 38 weeks. Doesn't have any labor pain. On examination, everything is fine. The cervix is 1 centimeter, 40%. Mid-pose. Station is -1. Liquor is clear, adequate. Administered test is okay. The question is now, do we induce this lady in the middle of the night at 11 o'clock? Dr. Parvati, what was your take on this?
So after doing an examination, quick examination of the patient, and particularly we want to know that the cord is not prolapsed once, because bag of membranes has broken. We have to rule out any evidence of the abruption or any evidence of fetal distress. Take a CTG and see that the fetal heart is good. If everything is well and fine, I would defer the induction till morning. I'll leave the patient with close monitoring of the FH and the maternal vitals.
Okay, so if there is nothing which necessitates an emergency delivery,
emergency induction is not
like an abruption or a cord prolapse, in most cases we would be fine with leaving the patient alone, waiting for spontaneous onset of labor, or to reassess after a fixed period of time. Now the question is, how long do you wait? Usually, you would wait till the next day morning around, whichever it is, 7 or 8 o'clock in the morning, and reassess her. Unfortunately, the evidence doesn't clearly mention how long you should wait, but clearly, if there is something like any of these conditions, then you would probably want to do an emergency cesarean and not wait for spontaneous onset of labor. And you definitely wouldn't wait till the patient, who's the first primary person to examine the patient, and then take the call accordingly. How would you like to induce labor in this patient, Dr. Prerna? Do you want to use prostaglandin gel? Do you prefer oxytocin? And there are some people who like misoprostol. What is your take on this? Is Dr. Prerna there?
Yes, yes, sir. So we can start with vaginal prostaglandin gels, and we personally prefer vaginal prostaglandin gels, and we can observe her for 4 to 6 hours and then give her the second shot if she doesn't progress onto the labor. But close monitoring is definitely required for hyperstimulation.
All right. So we can use prostaglandin gel even though the membranes are absent, but as rightly pointed out, it has to be an intracervical administration, not an intrauterine administration. Do not cross the internal os, otherwise you could land up with hyperactivity, tachysystole, and all the complications which follow thereafter. Anybody has any experience with misoprostol? Ajay Mane sir, you're in a teaching institution. Have you ever
misoprostol, 25 milligrams misoprostol is very useful in ripening and having we are using 25.
So we are using misoprostol for induction.
You're using it routinely?
Yeah.
And how
yeah,
do you
we are giving it
vaginally, orally, sublingually?
Orally. We give orally, 50 microgram orally every 4th hourly we give.
50 milligrams is a little high.
50 microgram. Sorry, sir. 50 microgram orally every 4th hourly we give.
50 would be a little high according to me.
But we have not seen. We haven't seen much of complications with 50, and it's being recommended by Earlier we used to give 25 microgram vaginally, but by keeping vaginally, we found that the incidence of PPH was a little bit high, traumatic PPH. So we switched over to oral PG even. And fortunately, so far, touch wood, as you said, not of much complications.
Okay. Dr. Ajay Mane sir, you were saying something? Sir, you are muted. Please unmute yourself.
PGE2 is not to be given in ruptured membrane state, no? As I remember.
Can be used, but then you have to monitor the patient carefully. Having ruptured membranes themselves do not preclude the use of PGE2 as long as it's not an intrauterine installation.
We also use 25 mcg misoprostols.
Yeah, 25 we are using vaginally is the most common application that we have encountered. 50 micrograms, according to me, probably would be a little high, but then medicine is from the beginning to the end. Individualization. So what works for Dr. Parvati in the south may not work for me, and vice versa.
Not only me, sir. In Kerala, the KFOG has recommended it. And,
I know. I'm just pulling your leg. It's a joke. Don't take it personally.
No, sir. No.
So let's go to the next case. This is a 33-year-old. She was diagnosed to have mild fetal growth restriction at 32 weeks. Conservative management was started. She has progressed well. And at 37 weeks, her color Doppler now shows reduced end-diastolic blood flow. CTG is showing low variability. There are no acceleration, but fortunately, there are no decelerations either. The cervix is posterior, long tubular station is high. In short, this is not a very inducible cervix. How would you like to approach this patient? Should we induce her? Should we wait for spontaneous labor? Should we do a planned elective cesarean section? What should be the optimal course for this particular patient? Anybody is free to take that.
Audible? Am I audible?
I think Dr. Sangeeta Agarwal is trying to speak. Yes, ma'am.
I will, because this patient is, we will wait till morning. First of all, I will examine her, and if patient is not in labor and she is having not having contractions, then we will wait her.
This is a patient with IUGR. I think you're referring to the previous patient. So this patient is the one who has IUGR, which was diagnosed at 32 weeks. Now she
In
has
this
reached
patient, I
37
will.
weeks, and her
Yeah.
color Doppler is showing abnormal findings. So should we
Okay.
deliver immediately? Should we wait? Should we induce? Should we do a cesarean?
No.
What should be
In
the
this patient, I will do cesarean section because she is having her CTG is reduced baseline variability and no acceleration, and weight is also 2 kg, and her bishop scoring is also too low, less than 4. That's I in this case, baby weight is also 2 kg. In this case, I will.
Okay. So
With
Sangeeta Agarwal madam prefers to do a planned elective cesarean section in this particular patient. Are there any differing points of view from anybody else on the panel? Please feel free to go ahead. Dr. Prerna, cesarean, induction. You are muted, ma'am. You'll need to unmute yourself.
Sir, since this is the 2 kilo baby and she is already having a altered Doppler parameter, we definitely need to counsel in thorough detail regarding the perinatal morbidity of the baby. Either we wait, either we go for a cesarean section, or whatever our plan of action is, we wait for another 1 week for medical management, whatever pharmacological agents has been given. But in my point of view, the most important issue is not delivery part here. The most important issue here is the perinatal risk associated with the baby, and delivery should be done in a place where there is an ICU facility or tertiary care level center. And that is what is the most important thing here, because this baby will definitely deliver one day or the other, maybe this week or the coming week. But the most important thing is the perinatal morbidity associated with baby, and that is the most important thing that we need to counsel the parents in thorough detail. What is the prognostic risk factors of the baby after birth, not during birth or before antenatal period.
I think that's also a very good point. Now, if I remember correctly, what I was taught is that the moment you have an absent end-diastolic blood flow, there needs to be an immediate delivery of the baby. If there is reversed end-diastolic blood flow, the baby has to come out on the same day. This is the general rule of thumb that we used to follow in old times when I had hair on my head. I was a much younger man. I don't know what the current concepts are, but most of us would be very scared of trying to deliver this baby vaginally. Number one, the cervix is uninducible. Number two, you will find that in a primigravida, the regular duration of labor is at least 10 to 12 hours. And whether this baby, even though it's now 2 kilos, is going to be able to withstand the stress of labor for 10, 12 hours and come out successfully vaginally, that's a very big question. So, on the one hand, I would agree with Dr. Sangeeta Agarwal that preferably sometimes in these patients where you don't want that headache, where you don't want that stress, and then to land up with an emergency cesarean section, sometimes it's better to do a planned elective cesarean section. But occasionally you will come across patients where they will say, "नहीं doctor, आप normally करो, कुछ भी होने दो, normally चाहिए हमको cesarean नहीं चाहिए, we cannot afford," or whatever is the indication, whatever is their reasoning. They will say, "नहीं डॉक्टर आप नॉर्मल के लिए ट्राई करो, अगर जरूरत पड़ेगा तो फिर इमरजेंसी में हम लोग सिजेरियन कर देंगे, we will give you consent for it at that point of time." So in this particular patient, what has happened is that there was thick meconium during labor, and you are going to do a cesarean section in labor for this particular patient. Is there anything which is going to be uppermost in your mind while you are doing this? Not all cesarean sections are equal. I think that is the theme of this entire panel, that cesarean may be one surgery, but the indications and the actual surgery itself vary according to the situation that you find yourself in. Dr. Ajay Mane sir, some of these points have been covered in the discussion. Would you like to speak about neonatology care and good close alliance between our NICU and cooperation between obstetricians and perinatologists? This is a very important point which we neglect to mention. We often don't even inform our colleagues until the baby is already out.
Yes. The neonatologist and the pediatric corner, this is a good thing covered in the Manyata. We must agree that it is a major point in the Manyata. So everybody should have Manyata affiliation with them. Invariably, then they must have a pediatrician and the warmer and every practice with the neonatologist. In tertiary referral centers, we are having NICU setups and the pediatrician. But in primary and secondary level centers, we don't have such facility. We call pediatrician. He comes with a single bag carrying only ambu and laryngoscope. And if something goes wrong, then we have to rush in ambulance. That is very scary situation. As on today, there is we are not out of that Consumer Protection Act. As of today, we are there inside. So we have to have cautious actions regarding this pediatric health.
Close association between us and our neonatology colleagues is very important. And I'm very fond of pointing out that the first moment when you diagnose antenatally itself that this is not a regular low risk patient, this is a high risk pregnancy, that is when we should have preferably a joint consultation or at least refer the patient to the pediatrician or the entire team who is going to look after our baby once it is born. That will go a long way towards allaying her fears. She'll be mentally, physically, and of course financially prepared for whatever expenses are going to be there separately for the baby. And they will be able to explain to her in words of one syllable, in simple language, what are the likely issues that this baby will face once it is born. It's not enough for us just to say, नहीं उसको नर्सरी में रखना पड़ेगा, कभी निकलेगा बोल नहीं सकते हैं, 10 दिन लग सकता है, 15 दिन लग सकता है, पता नहीं. Patients get scared when we as obstetricians talk to them like this. And relatives sometimes can come and hammer you for not talking to the patient properly if we continue behaving like this. So this is an important take-home message, closer cooperation. I want to ask everybody if they are using this WHO surgical safety checklist in their clinical practice. Dr. Parvati, madam, you'll need to unmute yourself.
Sorry, sir. To be honest, we are not using this.
Okay. Dr. Prerna?
Sir, our anesthetist is following a
Okay.
few of these, but we as surgeons are really in a hurry.
Yeah.
We are the worst.
No. Honestly, we are not using this. We have it, but we are not using.
Dr. Sangeeta Agarwal?
We are also not using.
So this is
We
the
are
fact
having
of
all
the matter
regards.
that though this has been prescribed by WHO nearly 10-15 years ago, and this is something which is mandatory for every surgery which happens in an operation theater, whether it's a minor surgical procedure or a supramajor heart transplant. This is one of the basic things which should be there in every documentation which happens for all our patients. If this is not there, it's one of the lacunae in our clinical practice. It's one of the deficiencies in our documentation. And as you are all aware, obstetrics and gynecology is the specialty where there is highest amount of litigation anywhere in the world. If you don't have a simple surgical safety checklist, induction checklist, documentation, signatures on paper with date and time findings, tomorrow, if for whatever reason this case goes to court, no matter how correctly you have treated the patient, your lack of documentation is what will land you up in a suit. So please be safe, be careful, and if you have time, please read this book called as the Checklist Manifesto. It's by a person of Indian origin and it's beautifully written. We have time to do one last case. We'll do this and then we'll close this panel. This is a lady who at 34 weeks has presented with a BP of 180 by 120. She is administered, you have given labetalol. While she is awaiting her blood test results, she has a generalized tonic-clonic convulsion. This is eclampsia. Of course, you know that this baby now needs to be delivered. Dr. Prerna, madam, how would you plan to do this delivery?
So
Is
first of
normal
all,
delivery possible in such a patient?
So first of all, we need to ascertain the maternal well-being in such a case. She already had an episode of eclampsia in front of our eyes. So we need to first address her airway, breathing and circulation, whether everything is in position. So most important is this. And we have to ascertain, we have to call for help. If we are alone, we need to call for help for a senior gynecologist. We need to address the issue of whether we are working in a setup where there is ICU, or we need to shift her to some other center where there is ICU facility. And after that, we need to assess the baby's condition, whether the baby is still having the FHR on, And if the baby is having an FHR on, after the stabilization of the mother with proper antihypertensive and anticonvulsants, and with proper risk assessment and counseling in thorough details regarding the perinatal mortality and morbidity risk of the baby, because she's only at 32 weeks of gestation, and her the chances of perinatal morbidity is very high. If time permits for the administration of corticosteroids, we can take a 48 hours duration for buying that amount of time for prematurity risk downstreaming. And then after 48 hours, maybe if she does not have convulsion between this 48 hours, we can opt for a delivery after 48 hours. And if she has a repeated convulsion, second episode of convulsion, even within this 48 hours of administration of corticosteroid, we need to deliver her at STAT.
So what would be your anticonvulsant of choice? Would it be magnesium sulfate, diazepam, or phenytoin?
So we prefer magnesium sulfate full dose from the onset of convulsion till 24 hours, whichever is delayed, or from delivery till 24 hours, whichever is later.
Thank you very much. So I think WHO, FOXY, and all the major bodies around the world are very clear that magnesium sulfate even today remains the drug of choice. We unfortunately, owing to lack of time, will not be able to go into the doses. But there are two regimens, Pritchard and Zuspan, whichever you're comfortable with, you can use. The IV regimen is preferred more and more now because it avoids the complications of intramuscular administration of magnesium sulfate. Many of the medicine colleagues who come and see our patients, whether it is to do fundoscopy or whether you are taking a multidisciplinary approach to get an opinion on paper, will advise phenytoin, and they are very fond of this drug. But then we have to be careful that while the patient is at least under our care, we are following the standard WHO protocols. If the patient is out of our hands, transferred to an ICU, is primarily under ICU care setup, under a medicine or an intensivist person, then probably they would switch over to phenytoin because they don't like magnesium sulfate too much. Let's talk a little bit about how we are going to deliver this baby. For all practical purposes, a vaginal birth may not be something which is practical or possible unless the cervix is already 2-3 centimeters open, the head is low down in the pelvis, and you anticipate that within maybe an hour or two it's a multiparous patient, then she would deliver quickly. For all other patients, probably you would do a planned cesarean section. Right? But having said that, as we said, cesareans for patients who are eclamptics are actually very dangerous surgeries, and we need to keep a lot of things in mind when we are doing this cesarean. Dr. Parvati, would you like to talk about this?
So cesarean is very risky for a eclamptic patient, but here we have no other choice. It is a preterm, and very less likely chance that she may go in for labor, either by spontaneous or induction. And it's dangerous to keep her undelivered for more than 10 to 12 hours. So it's always better to resort to cesarean in such a case. And we need a close cooperation with our anesthetist. They should be informed of the each and every drug that we have given to the patient, whether it be the antihypertensive or the magnesium sulfate, because some of the drugs which they give, if they resort to GA, may add up with the action of magnesium sulfate. So the anesthesia, usually they prefer epidural, and if the platelet count, in this case the investigations are normal. In case she is in some help or something, then they may resort to GA. In that case, the intubation part is very risky for them, especially this patient is having abdominal wall edema, and also we can expect a laryngeal wall edema for that patient, and it will be a very high risk patient. Induction itself can cause cardiac arrest for the patient. So as in our case, call for help is needed for an anesthetist also. A single-handed anesthetist, it will be very difficult to give anesthesia in a case of an eclampsia. So we should make them aware of all these problems in this patient before you shift the patient for cesarean.
And again, because of magnesium sulfate itself, sometimes you may land up with atonic PPH, with atonic the hypertension PPH. And the atonic PPH. This is something which is a nightmare for us. It's always better to have seniors present with the full team that is there. Even if it turns out to be a routine cesarean and everything goes well, post-delivery the patient may still come up with a convulsion. She may present with other complications. So ideally, this patient should be in an HD or an ICU setup for at least 24 or 48 hours before she is completely controlled, and then she can be taken out to a routine postnatal ward. Dr. Ajay Mane, sir, can you tell us some of the medico-legal issues which are commonly happening in eclamptic patients, starting right with their documentation and how we tackle patients, how it's incomplete on our part sometimes to not talk about the various issues that we have tackled.
Basically, we have to have a counseling, as Parvati ma'am saying, we have to have counseling, and as you said correctly, the counseling should be on the paper.
Sir, you are muted. You'll need to unmute yourself.
Hello.
Yes.
Is it okay?
Yes. Sir.
As you said correctly, the counseling should be done and it must be taken on the paper first, because this is the paper who save you in the court of law. Second, the consent of the if and but. It is to be told them or counseled them in their own language and to be mentioned on the paper that this is the other factors. And if the patient is convulsing, take the consent of their near relatives who is along with the patients, and then only proceed with the surgery or whatever you want. But at this time, you must have a senior or a colleague with you, obstetrician, as you said correctly, another anesthesiologist and a pediatrician who is there. Meanwhile, between the High Court has given an order that each and every tertiary center should have ICU in the hospital premises, which is not possible. Each and every, only medical colleges and the corporate hospitals and tertiary care center, they are having ICU and HDU. So it is not mandatory to have an ICU in the hospital for obstetric care. I just wanted to tell you in between. But the documentation must be clear on the paper. We must have a signature and the left thumb impression of the patient's relative who is responsible for her care. As they may deny that the doctor has not told us about the consequences and the complications and the baby has gone, whatever, but they cannot deny the left thumb impression. So we must have a thumb impression along with the signature. And doctor must do his signature on that consent form, as it is agreement between two persons. The doctor's signature is mandatory, then and then only it is a valid consent. Okay?
One more point, sir.
So I want to add one point.
Yes, please. Dr. Parvati first and then
Yes,
Dr. Prerna.
Sir, the thing is that, as Ajay sir told, if the patient is to be shifted, means it's not a case to be operated in a small nursing home, or it should be done taken care of in a tertiary care center. But before you shift the patient to the tertiary care center, make sure that you give the loading dose of Maxilf, because don't delay the Maxilf. That itself can cause maternal mortality. Give the loading dose of Maxilf and write it on the referral paper, because once the patient reaches the referral center, if they don't see this Maxilf dose being given, they will again load it, which can lead to magnesium sulfate toxicity. So giving the loading dose of Maxilf and documentation of it on the referral paper is very important in this case.
Referral chip, we are having a good criteria of referral chip. Whatever we have given is to be mentioned on the referral sheet and to be sent with the patient. One copies to be kept with us because they may lose it.
Thank you, sir. Dr. Prerna, madam.
So a very important issue that I want to highlight out here is that since eclampsia is the second most common cause of maternal mortality in our country after hemorrhage, we need to first assess the patient in complete detail antenatally, that whether she has any risk of eclampsia when she's developing a little bit of hypertension in pregnancy, and we need to see all her markers that whether she'll proceed on to being eclamptic. So it's not that eclampsia happened in one day. What are the predictors of eclampsia? We need to assess this patient in complete detail because she was a high-risk pregnancy already, an IVF baby she was having, and we did not assess the patient for the parameters which are predictors for eclampsia. So this thing we need to really assess her antenatal.
Thank you so much, everybody. I think we had a fantastic panel. Thank you to all my eminent panelists. I think a couple of them had some audio-visual issues. Apologies for the same. And if there are any audience questions, Dr. Anjusoni, madam, would you like to put them to the panelists?
On behalf of all panelists, I must thank you to Pratik sir for conducting a beautiful panel and giving more answers than us. Thank you, sir. Thank you very much.
I saw one or two questions in the chat box.
I can't see anything.
Dr. Sundari has asked, should you give steroids at 32 weeks when you have detected IUGR? Anybody on the panel is free to speak?
Yes, so you can give steroids if it is detected at 32 weeks.
Yeah, so I think you can do we all of us do give steroids. There is nobody who would say no, don't give steroids. But the traditional teaching always has been that IUGR itself is a state of stress. And in case of IUGR, the pulmonary maturity or lung maturity, what we call, happens naturally before 36, 34 weeks anyway, as compared to a normally growing pregnancy. So whatever steroids you're giving is just as a backup. Probably the lung maturity has already occurred. But having said that, there is nobody who would say, no, don't give it, because it definitely doesn't do any harm. Even if it prevents one ICU admission, I think all of us would be very much in favor of. Is Dr. Abharani Sinha here? There was one question for her. I think she has left. She is no longer with us. And the question
There was one question
regarding,
related to the rubella. Starting, I heard that.
that is already tackled, sir. It's done.
Okay, fine.
We already
Because
finished that.
if it is IgG positive, nothing to be done. If
No,
it is
I said
IgM,
that if it is an active infection, it's an active
IgM.
rubella in the current pregnancy, that is when all the
that is to be
complications.
handled.
IgG is anyway, all of us are IgG positive, I think.
IgG actually says that the patient is already immunized. We don't need to
Precisely. All of us are IgG positive.
Yes.
So any closing remarks from all the panelists before we wind up? Dr. Parvati, any take-home messages for the audience, ma'am?
Sir, majority of the maternal mortality is preventable, whether it be hemorrhage or be hypertension. And so we need to keep a close watch on it from her first visit itself, and consider this topic, that is reducing cesarean section, by choosing the correct mode of induction, and by our close monitoring of the patient and all, and just by seeing just a dip on the CTG, thinking that it's proper interpretation of CTG is also very important. So all these factors can help you in reducing the cesarean section, because cesarean section is going to be a big menace later. Nowadays, the incidence of placenta accreta, percreta, and creta are all at a higher rate. So that will be creating more problem for the patient in the future pregnancies. So she should be made aware of the benefits of vaginal delivery compared to the cesarean section, and so that the patient won't stress us for taking her for a cesarean delivery.
Right. Dr. Prerna, you will need to unmute yourself, ma'am. Please go ahead.
As you have mentioned that the maximum amount of litigation happens with obstetric cases in India. So we need to be very, very vigilant in our documentation process. Little documentation, little support, no documentation, there is no protection. So we need to document our work very, very closely, and also communication with the patient and his or her relatives, because communication is developing our communication skills as well as our hospital staff, and counseling the patient in thorough detail regarding the pros and cons of every procedure that we are undergoing with the patient is the key towards having a healthy practice.
Thank you, ma'am. Thank you so much. Yes, Dr. Ajay.
Obstetric practice is unpredictable anyway. We can have problem at any stage. Everything goes smoothly, and at a certain point we can have a big problem. So prediction must be there in your mind. First thing. Second, training to our staff is must. And third, the documentation, as you said, documentation and medical legal side must be up to date to save us from all complications.
Can I also comment?
Yes, of course, ma'am. You're the convener. You don't need permission to speak.
I have to tell one thing, that we have to conduct drills, we have to train our staff, we have to create teams, team of nurses, team of doctors, and you have to have, people say we don't have ICU facilities, but we can have at least HTU facilities, which are not very difficult, because as Ajay just said, that every delivery is unpredictable. So having an HTU facility is a must, and you must have it. You cannot take chances in today's era, and you have to conduct this, teamwork and protocols and trainings about PPH and about, all drills, eclampsia drills and all these drills. You have to keep training your own staff, your own doctors. That is the must in today's life.
Thank you, ma'am. Is there anything else that anyone else wants to add?
Sangeeta was there. She wants to tell something. Dr. Sangeeta?
Yes, ma'am. I want to add proper documentation and proper counseling is must. In our setup, we have to counsel each and everything, and we have to be friendly with patients. During labor, during delivery, patients are so conscious and over conscious. We have to be fair, friendly, and we can allow their relatives in labor room to overcome their over consciousness. एंड वी श्योर मैम, ये अकॉर्डिंग टू यू, जैसे आपने कहा भी कि वी हैव टू drills according to Foxy, and we have to work according to Foxy guidelines, and we should do drills in with our staffs to avoid or to for proper communication with the staff. Sometimes staff is not saying anything, and patient is landing in problem. Then patient should proper counseling is there, and during antenatal periods we have to some yogas and dietary habits, and for exercise we should follow, we should told them.
Okay, ma'am. Thank you so much. Dr. Anju Soni, ma'am. Thanks to your leadership skills and your communication, we have an audience of nearly 750 who are.
Great. Congratulations. No, Pratik, it's all your doing. You are a. Ajay, am I right or wrong?
50% credit to Pratik sir and 50% to Anju ma'am.
Pratik is a icon, you know. Wherever he goes, people follow. Congratulations, Pratik, for conducting such a beautiful program and bringing this program to Rajasthan. I think I give you all the credit. You are a great guy and you are a great academician, and you carry everybody along with you. Congratulations to you, number one. Congratulations to all the speakers, all the faculties, all the panelists. It was a beautifully conducted panel by Pratik, and all of you responded so well. All of you were, you know, for me it was so difficult to sit quietly and not speak, you know. I had to literally.
You're welcome to speak. You're the convener. You don't need permission to speak.
I mean, it was so difficult to keep quiet. Pratik, don't give me this punishment in future. If ever, you know, you can't just keep quiet like that, you know, and watching everybody and can't comment, you know. So I'm sorry that I'm telling you this. I want to thank all the presidents and secretaries of societies. Of course, they were not able to be there because of some problem of internet maybe and their emergencies, but I'm really thankful to them for their support and guidance. I'm thankful to all the participants who are there and who have been here all the time logged in. Thank you all the participants. No webinar is complete without your being there. They are the main thing. And thank you to the pharma companies who have really given good support to us, because without you people, we will not be able to continue our education, which is the most important thing. And this era of COVID, I think you have given us a lot of support. Thank you very much. Thank you, Pratik.
So to add to the formal vote of thanks, we need to place on record our gratitude to the AMOG's President and Secretary, Dr. Nandita Palshetkar, and Dr. Arun Nayak, my co-convener, Dr. Anju Soni, our chief guest, Chairperson of ICOG, Dr. Mandakini Meg. Thank you also to Dr. Parag Biniwale, Secretary, for granting us the ICOG credit point. Dr. Niranjan Chavan, our guest of honor, we wish him all the very best in his further journey in IG. For the two speakers, hats off to them, Dr. Sarita Bhalerao spoke on recurrent pregnancy loss, and Dr. Abharani Sinha, in spite of being stuck in rain and traffic, still managed to deliver a wonderful talk on malaria and dengue in pregnancy. Thank you to Dr. Geeta Balsarkar, Dr. Dinesh Pradhan, Dr. P.K. Sidhu, Nidhi Barkunya, and Renu Setia, the presidents of the four societies, Bharatpur, Sri Ganganagar, Kota, and Hanumangarh, and to all my excellent panelists. All of you have already been thanked. Thanks are also due to our education partners, Bharat Serums and Vaccines, and Science Integra, Meenal, Subbu, Patient, Rimon. All of you have been a wonderful backbone of support to all of us. Thank you so much for being here. We'll see all of you very soon. Thank you for logging. Bye for now.
Thank you, Pratik sir. Thank you.
Thank you, Pratik. Congratulations once again.